Right, we will resume our hearing of the UVM Health Network Hospitals. Ms. Noonan, I see that you are here, so we'll turn it to you and your team for your presentation on your budget.
Great. Thank you, Chair Foster and members of the board, for the opportunity to meet with you today. Central Vermont Medical Center submitted a FY26 budget that's compliant with the Green Mountain Care Board budget guidance that includes a 3.6% commercial rate decrease, a 3.5% NPR increase, and a 2.8% operating expense growth. To clarify, our submitted narrative noted a 3.3% commercial rate decrease, so I just wanted to call that out. Our budget balances quality, access, and cost with CVMC's long-term sustainability to care for the 66,000 people who live and work in the 26 towns and cities in Central Vermont. This year's FY26 budget submission, coupled with the mid-year adjustment proposal that we discussed last Wednesday, and the discussion we'll have on the 13th, reflect our commitment to balancing affordability while ensuring quality and access to the vital healthcare services that Central Vermonters need. In FY24, CVMC achieved a positive margin of 1.7%, our first in 8 years, following 7 consecutive years of negative operating margins, ranging between a negative 0.6% to a negative 6.5%. That margin was achieved by providing access to services that our community required. Fiscal year to date, CVMC has a slightly favorable positive margin, and in FY26, we essentially budgeted at break even. We must remain financially stable to provide care and services, appropriately invest in the equipment and facilities, and most importantly, continue to offer competitive wages and benefits to our most important resource, our staff and providers. CVMC utilizes lean and other methodologies to improve the efficiency and effectiveness of our services. To date, we have put 240 members of our team through intensive lean education. Huddle boards, a methodology to track improvement, are openly displayed in units and departments across CVMC. The staff run those huddles addressing operational and clinical issues that arise real time, along with tracking and trending performance on key clinical and operational metrics over time. In May of this year, we held a quality forum. This forum highlighted 49 improvement projects from across our organization. Each project exemplified our deep commitment to improving quality and safety of the care and services we provide. 5 awards were presented to teams who demonstrated exceptional improvements in categories such as stewardship, innovation, patient-centeredness, simple solutions, and partnership. An example of one of these awards was presented to the emergency department and care management teams for their efforts to identify ED patients who did not have a primary care provider. The project goal was linking patients to a PCP, and that effort has begun to show a positive impact on reducing some of our ED utilization. Our improvement efforts also focused on hospital-acquired conditions. Since March of 23, we've had 0 central line-associated blood infections. We've had 0 catheter-associated urinary tract infections since October of 24. And fiscal year to date, we've had 0 surgical site infections in our total joint procedures. Fiscal year to date, these performance improvement efforts have also resulted in a reduction in falls, pressure injuries, length of stay, and readmissions. This progress, however, is not reflected on our CMS star ratings due to the lag in data for this public reporting, which includes data from 2019 to 2023 for Medicare patients. Our care teams will continue to actively work to improve our performance so future scores reflect the quality that we know we deliver every day. CVMC is the only community hospital in Vermont to receive certification as a primary stroke center. Primary stroke centers are associated with reduced morbidity, and multiple studies demonstrate a decreased 30-day and 1-year mortality for patients cared for in these centers. CVMC is also a resource for intensive care and acute care services for 8 out of the 14 hospitals in Vermont. This new referral pattern frees up capacity at UVMMC for the tertiary care only they can provide. In addition to clinical efficiencies, CVMC is reducing administrative costs by $2.8 million by working collaboratively to streamline and address redundant administrative services both here at CVMC and across our network. This includes the elimination of 8.4 FTEs in leadership roles, a $1.1 million expense savings. Through innovative workforce development programs, which began here at CVMC in 2020, we've graduated 41 LPNs, 22 RNs, and 1 respiratory therapist in the last 5 years. These programs are now part of our systems level Center for Workforce Development. Efforts like these have enabled us to reduce our travelers by 23.2 FTEs for an estimated savings of $3.4 million in fiscal year 26. Additionally, to promote workforce recruitment and retention, CVMC leases 20 market rate rental units within 5 miles of the hospital campus and subleases these to CVMC employees. To support the expansion of much needed childcare for our team, we've made an investment in regional childcare provider, which will be located near the hospital campus. We will have 25 spaces per year for the next 5 years reserved for CVMC families. In addition, the UVM Health Network's housing and childcare initiatives in Chittenden County are available to all system-level employees. In fiscal year 26, CVMC will continue to fund our employee share of the child care contribution that was enacted in July of 24. These efforts, in addition to more traditional tuition reimbursement and wellness programs, are all ways in which we support our team. In the area of external partnerships, I want to highlight Thrive, Central Vermont's accountable community for health. Pardon me. This regional collaborative was created to address the social drivers of health and improve the well-being of residents in Washington and Northern Orange counties. CVMC serves as the convener and fiscal sponsor for this 20-partner organization. Thrive's focus is aligned with priorities identified in our community health needs assessment, which we just recently completed. These initiatives range from sponsorships of programs that address substance use prevention and treatment through the work of the Central Vermont Prevention Coalition, which we are the conveners for, to a campaign focused on lowering the rate of single female head of households living in poverty. And this year, Thrive was honored to receive the Public Health Champion Award from the Vermont Public Health Association. The award was presented at the association's annual meeting and recognized Thrive's work in promoting public health, our effective and collaborative response following the regional flooding that we experienced in the summer of 2024. As I mentioned, over the last 9 years, we have leveraged Thrive's partnership with their employees and their client base to complete our community health needs assessment. We've identified our identified needs for this fiscal year and for this 3-year cycle are also in alignment with the state's 2025 to 2030 health improvement plan. Next slide. Our primary care providers have completed the transition to tracking productivity using a risk-adjusted panel size. This, coupled with improvements that you heard earlier that are related to operations, such as standardized schedules, has allowed CVMC to create more access to primary care. As of March of this year, we now have 24/7 coverage for our certified nurse midwives for our labor and delivery service. This has been a strategic priority for CVMC for some time, but it was just actualized this year in March. CVMC providers have performed over 1,200 electronic e-consults, a 15.6% increase over this time last fiscal year. As mentioned earlier, an e-consult gives primary care providers the ability to ask a question of a specialist through the EHR. And we feel that about 80% of the time, these e-consults result in the patient not having to be referred to a specialist. This frees up time for the specialist to see other patients and reduces costs as e-consults are billed at a lower rate. Enhanced referrals that you also heard mentioned earlier can clarify tests that may be required prior to seeing a specialist. This process avoids visits where the patient was seen by a specialist only to find they needed a test in advance of that visit. We are continuing to standardize ambulatory clinic schedules. This work has been completed in primary care, cardiology, and endocrinology, with plans to spread this to other services across the next 18 months. Standardized scheduling allows patients to leverage digital tools such as the cancel and reschedule function to optimize the provider's schedule. We are on pace to have 1/3 of our practices utilize this function by this fall. Lastly, I want to mention our Skilled Nursing and Rehabilitation Center, Woodridge. rehabilitation, and nursing. Woodridge falls under CVMC's tax ID and is integrated into the CVMC's fiscal year 26 budget. With our aging demographic, the demand for post-acute services continues to increase. As a system, we have aligned these facilities under a single division to gain efficiencies and continue to focus on improving outcomes. The FY26 budget for Woodridge reflects an average daily census of 145. Our commitment to provide post-acute care services, improving throughput by reducing the number of long-stay patients in our acute care beds, and providing resident-centered care in a more appropriate setting is our goal. In closing, CVMC remains committed to our efforts to improve quality, maximize the efficiency of our operations, expand access, and address affordability for those we serve. We also stand ready to advance collaborative partnerships to support these goals. And now I'm going to pivot and introduce our CFO, Kim Patnode, who will review in more detail our budget proposal. Kim?
Thank you, Anna. Thank you, Chair Foster and members of the board for allowing us to present our budget for the 2026. I'm going to give you a little bit of a background on where we're at for fiscal year 2025. Right now, we're looking at net patient revenues exceeding budgets by about $10 million, which is 3.5% of what we had initially budgeted in 2025. 56% of that variance is related to utilization, particularly in the areas of outpatient services for endoscopy, I can never say that word right, for GI services, imaging services, which include diagnostic, CT, PET, ultrasound, lab services, and pharmaceuticals. Of that $10 million, approximately 6.5 of that is related to major commercial payers of Blue Cross, Cigna, and MVP. We are instituting a mid-year rate reduction that we did present to the board on August 6th. That is about a $6 million reduction to our commercial payers of those same three that I mentioned above, Blue Cross, and Cigna, and MVP, to reduce our reduce our burdens to our commercial payers. In the same net patient revenue space, as Anna alluded to, we have Woodridge Rehabilitation and Nursing Facility that is in our budget numbers, and they have a $1.9 million unbudgeted favorable variance, and that's related to the extraordinary financial relief funds that we applied for in the April-May time period of last fiscal year, which is on a state fiscal year. We heard in January of 2025 that we received this enhanced payment for our Medicaid residents, and that was in effect from January to June. We did not put this into our budget for 2026, as the nursing homes are in a rebasing period for 2026, and the need is not there. Our expenses are coming in over budget by $15.8 million, or that's 5.1% budget variance, and there's contributed to 6 areas. One is our staff salaries. We're $7.1 million over budget. And that's really tied to the fact that you will see later on our presentation that we have 3 union bargaining units now that are in our encatchment areas, one for RN, technical professional, and most recently the support services union contracts. Our fringe benefits are also $4.4 million higher than budgeted, and that is again related, as with everyone else, a higher employee healthcare costs as well as pharmaceutical benefits. Our traveler use continues in 2025 to be $3.2 million higher than budget. And that is not only just in nursing, but also in our ancillary spaces of respiratory therapy, imaging, and our nursing home. Our medical staff salaries are $2.3 million. Our pharmaceuticals, as the revenues are increased, so are expenses, and that's really related to our higher cost oncology services. We do have a couple other areas in our purchase services that are coming in above budget. One is anesthesia coverage. We have a hold harmless arrangement with the UVMMC Health Center, and that is a hold harmless arrangement with the anesthesia providers where we pay the difference between what a physician is paid versus what they bring in. And we are having to rely on a little more on locum coverages, so the locum does cost us more. The other cost in our purchase service space is also in our Woodridge Rehabilitation and Nursing Services, and that is for a management contract. On the next slide, you will see our overall utilization areas. Most of our volumes are within the 5% FY25 budget, with the exception of 3 areas. That's inpatient resident short stay rehab services. We'd originally bumped that resident stay to an average daily census of 145. We are getting there, but at the beginning of the fiscal year, we were struggling to meet that dollar amount, that ADC, and I'm most happy to report in the last couple of months, we are hanging around the 140 mark. So that means we're getting the right patients at the right level of care. We are still seeing higher volumes in our CTs. That is coming mostly from our ED areas. And as Anna alluded to, we do have the Joint Commission certification for our primary stroke, and that we're seeing a lot more utilization in the CT scans to rule out strokes. And our GI is running higher. As a reminder, our GI services are primarily driven by by an independent GI group that is part of our team. Moving on to net patient revenues, again, just a real high level. I want to clarify, our narrative did say we had a 3.3% commercial rate reduction. It is actually 3.6%. The delta between the 3.3% and the 3.6% that we are proposing is about $500,000. Excuse me. I'll break down that 3.6% commercial rate reduction in the next couple slides. And we are looking at a 2.8% overall operating expense growth. So where are we at moving from fiscal year 25 to 26? We are putting in a 3% charge master increase, very similar to what UVMMC has provided for an answer on their charge master increase. When we do our budgets, we do look at several things. We build our budget based on utilization. What do we anticipate our budgets are? Again, we are building a budget with a very short time frame, looking from October to January time period, and then look in the prior fiscal year to see if there's anything different we've missed in the historical that we need to incorporate into the budget. We also look at different things, including new recruits, departures. New recruits, obviously, in the physician space need to always have ramp-up time, so we have to make sure we adequately account for ramp-up time. Any technology changes, I think one of the questions came, are we using AI? Is there AI that will help us enhance our efficiencies, access initiatives? And then the seasonal factors that are not included from October to January. Typically, if you look at January, February, that is your higher inpatient utilization. So you don't want to build an entire budget build on the January, February time period. In our net patient revenues, we are primarily driven by our utilization, and the rate adjustments are estimated to be minimal. In our expense pace, where we are looking at for the 3% in guidance, we have a $5.1 million increase due to inflationary costs, which are more than half salaries. We have $1.9 million increase due to volumes for pharmaceuticals and supplies, a $1.5 million increase due to medical staff salaries, and then we have a $6.3 million efficiencies for clinical that are going to be reducing expenses. As part of being part of the network, we also have the opportunity to lean in and really standardize a lot of our care and making that happen as a team. Overall, CVMC is reducing our overall staff FTEs of 34. This is inclusive of 23.2 FTEs, and that is not only at the hospital, but at the nursing home as well. Overall, volumes are continuing to trend within 5% of our 25 budget, with the exception of 4 areas. Our clinical visits, we are expecting a 4.4% increase as related to the improved access that Anna indicated. We've increased a bump in our CT scans. We anticipate that's going to continue to be above our budgeted volumes for 25 and for the stroke rule out. GI cases, again, working through those backlogs of cases that we had with our independent GI group. And then our billed lab tests. We have one of the rare opportunities is we have increased our reference lab capability, and that's really done through the lean work that the lab department has done to create efficiencies to take on more tests. Moving into the net patient revenue assumptions specifically. You will see on this slide that we do have an update also in this slide as well. We have updated numbers for our Medicare increase or decrease, I should say. It's a net decrease of $511,000. We are broken that down between inpatient improvements of $415K and outpatient services is a reduction of $927,000. CVMC will have to make up the differences and with additional focuses on effort for efficiencies in our efforts. We are not anticipating any FPP adjustments. Our net patient payer mix, as you can see, there's a very small shifts between payer mix and overall. The reduction in net patient revenues from payer mix is about $1.4 million from the FY25 budget. Just as a reminder, we are highlighting the major commercial budget decreases. On the next slide, I will talk a little bit more about how that 3.6% reduction in commercial rates or commercial rates will occur. In our budget narrative, we did, as I said, note that we had a 3.3% major commercial rate reduction, but it really is a 3.6% that does tie to our rate decomp file. The difference, again, just to confirm, is about $500,000. When we started our budget, you'll notice that our commercial rate increase is 2.3%. That is really it's about 3/4 of the 3%. That is part of the allowed budget increase because our rates don't go into effect until January 1st. But when we were putting our budget together, we weren't clear on what the Act 55 pricing reductions would go into effect. And at the same time, we were planning a mid-year rate reduction. We thought the Act 55 would go into effect on July 1st, which might negate the need for a mid-year rate reduction in 2025 fiscal year. We budgeted a 12-month impact for the Act 55. Now that we know that the Act 55 is only going to be 9 months affecting the fiscal year 2026, the true impact will be $5.6 million instead of a full $7.5 million that we budgeted. This gives us a little bit of wiggle room to continue to look at increasing and improving any efficiencies as well as access. Moving into our bad debt and free care slide. We have not adjusted for anything material. As part of the UVM Health Network, one of the things that is really a benefit to us is we have standardized our free care practices and policies, and it's a centralized services that is through shared services. So any patient who calls in will get the same level of care regardless of which partner hospital they are engaging with. Moving to case mix and operating mixes, you'll see our case mix is relatively flat. We have a very heavy medical population, which means we don't see a lot of variation in our case mix index, either between Medicare or all payers. I would be remiss if we didn't talk about what does this mean and where do we land in our operating metrics. You can see from our operating margin, we are making a very slim to no margin. Our days cash on hand is very low, between 73 to 79 days cash on hand. But the good news is we do have the ability to take on debt if we needed to. Moving into other revenue, the majority of our other revenue that shows up for CVMC is really in our 340B space. We are anticipating some reduction as to do with additional manufacturer restrictions. Moving out of labor and moving out of revenue and into expenses, we have very high level of what we're looking at. Total FTEs, again, as I note, we have an overall reduction of 34 FTEs, which includes 23.2 FTEs that are travelers and the eight leadership positions that Anna noted from the beginning of our presentation. Overall, our total expenses and labor, we are anticipating $5.1 million related to inflation, which is more than likely most of our salaries. We have $1.5 million that's tied to our medical staff, and we also have $5.2 million increase in our employee benefits. This is a new slide for us. As I had started in our conversation, we have our union contracts and our non-union for our non-union employees that work at CVMC. We have several contracts you'll notice that are also tied to UVMMC that are on ours as well. These individuals work here on CVMC campus, and that's why we picked up their contract amounts in our budgets. We have about 58% of our staff that is new to us, that is under a contract and is higher than the 3% allowed budget variance or the inflation variance that the Green Mountain Care Board has offered. We've also moved into our non-salary expenses. I've broken this down between the several factors. One is, what is the increase related to our budget increase for non-labor expenses between utilization, inflation, and other factors? Other factors, we're looking at reductions, you will notice, in spaces around creating additional efficiencies. That is the biggest driver in our other factors. I will also tell you in our utility space, that is a little bit of a bigger bump from year over year in our budget. We had a 5-year contract that ended with our natural gas vendor. Very, very few choices to come into this space. 5-year contract ended. The vendor came in and came back with a pretty substantial increase that we're having to absorb as well. So with all of the changes we're making with Act 55 and to continue to make our system as affordable and accessible to our community members, what are we doing for major savings and financial impacts? We have our traveler reductions, this 3.4%. Or $3.4 million. We're reducing our administrative expenses and then our cost of care expense reductions. Again, as part of the network, we're able to really lean in and standardize our care as physicians and staff migrate from one of our partners to the other. And I'll turn it back over to you for closing.
Yeah, so I think we just provided a high-level overview of our FY26 budget submission. We're seeing that we're in compliant with the Green Mountain Care Board's guidance. And at this point, I just turn it back over to you, Chair Foster, to open us up for questions.
Thank you both very much. I forgot to announce one procedural step, which is Dr. Merman will not be participating in the CVMC budget as in years past, and he has stepped out. He's recused himself from this matter. I'll turn to Member Teachout for her questions.
Great. Good afternoon. Thank you. I appreciated the clarity, but I just want to make you go through it one more time. The differences from what you're truly asking for and what was in your narrative and other documents. So instead of a 3.3 commercial rate decline, you're asking for 3.6. And you said the difference is about $500,000 between those two. Also on page 7 of your narrative, you say that you're asking for a 3.03% charge master increase. And now it looks like that's just a flat 3.0. Am I correct?
That's correct.
Okay. And then again, same page, I think you showed in your slides new commercial numbers that put you at negative 3.6 for inpatient, outpatient, and professional. Okay. And is that the same numbers that you would also use on page 15 of your narrative? It looks like the same chart repeated.
Let me just pull up that narrative real quick.
And I guess just to ask my question, you've got a 3% charge master change increase for next year. How do you plan on applying it across inpatient, outpatient, and professional? And is that what I'm looking at here, or is that something else?
I'm going to, if Kelly Shapney is on, she is my resident expert on charge master increases, and I'm going to look for that, page 15, member
Okay.
teaching.
Hi, Member Teachout. Yes, we're looking in aggregate inpatient, outpatient, professional. The per code or area is actually still in development, given we're pending budget decisions, but that is in aggregate how we're looking to apply the charge master.
Okay, and I guess when you're looking at the budget this morning, you had specified how it would go across the 3. So I wasn't sure why you couldn't do it here.
I don't think I said it it's a similar answer, and if I misstated or said it in a different manner, what I said earlier and how we apply charge master increases is in general to get to the aggregate 3% due to various needs, again, going back to the conversation of lesser of and identifying codes that have moved around. And, with our payer revenue, there could be some tweaks, but it's a similar. And if something was said differently, it is in the same approach that we take at CVMC.
Okay, I guess then to zero in on the outpatient, you have for CVMC an even number. And I thought that the difference before was attributable to the H266 cap. And so I was just curious that it didn't show up in a similar way in CVMC as it did in UVMMC.
So I think there's two components. I'll start and then turn back over to Kim. In terms of during the legislation and H266 at the time, the largest revenue impact, as you saw, is at the medical center, and we did a lot of analytics and were able to drill in. Given the timing of budgets, both with CVMC and I'll say with Porter, and the different impact, getting to honestly the impact of the drug purchasing capabilities at both hospitals, because it is different from the 340B status. The budget doesn't reflect the nuances we were able to capture in the medical center. A lot of that was timing, given when the legislation came out, us not knowing July 1st versus 1/1. So that's a reason why there's differences between the two budgets.
Okay,
Kim,
thank
feel
you.
free to add anything, but that's the general answer.
No, that's what I would have said too. Thank you, Kelly.
Great. So I will jump to a different question. I wanted to ask about how CVMC benefits financially from being part of the health network.
Well, I'll start and then I'll let Kim jump in. So I'm going to approach it more from clinical and operational perspective. So CVMC, I would say, has benefited from being part of the network in a number of ways. First and foremost, if CVMC was standalone, we would not have the EHR capacity and other type of system level IT tools would not be available to us as a community hospital. Being part of the network has allowed us to really leverage those tools, which have optimized our efficiency in many ways and absolutely has helped with improving our clinical outcomes. So that's a very simple but broad example of the value of being part of a larger network. Another area that's been helpful to us is in recruitment. So working with the departmental chairs, our chief medical officer, Dr. Clauser, and our team have been able to really recruit key professionals, particularly in the specialty category that we in the past had struggled to recruit into our organization. And those individuals now are being recruited into practicing at UVMMC as an example, and also CVMC. So they go between partners, which is really helpful. So that's just a few examples. And I think it also works in the reverse. CVMC had some real innovative practices in the workforce development programming that we launched in 2020, and those are now spread across the network, right? So I think those kind of collaborative efforts go a long way into optimizing our clinical outcomes, but also improving the efficiencies of our operations. So that's just my piece of answering that question. I don't know, Kim, if you want to add anything more to that.
Yeah, the level of expertise that our network does bring would be something that we'd be remiss at having to probably outsource more, particularly like cost reporting, reimbursement. And we also are able to create efficiencies through our revenue cycle. We are completely consolidated as part of our shared services and revenue cycle space. We've also been able to lean on our network in spaces like payroll processing. We had an individual leave several years ago. I chose not to replace that individual, and our network colleagues as part of the shared services leaned in and helped us take care of our payroll issues here at CVMC.
So do you benefit from every one of the shared services that are available through being part of the network? Or are there ones that you use more than others, or do you pick and choose what's most appropriate for your organization?
So as part of our shared service model, we have the opportunity to access any shared service that's available. So I would say that there's some that we use more than others, but by and large, what we've done is instead of having those resources local at CVMC and investing locally in that, those services are now part of the network. And so we can optimize just by scale those kind of resources versus having to have one of each of those types of services within our own organization. So I think overall, it's really an efficiency opportunity. And out of that has also come a lot of standardization, which I think anytime you standardize, going back to putting my lean hat on, you end up reducing waste, right? I would say that it's overall advantageous for CVMC to have the ability to access those resources and shared services as needed. But some of them are standardized and across available across all partners.
Great.
And that's the intent. That's the intent.
And then would you say that the benefits have grown over the course of the arrangement?
Well, I think more and more shared services have, more and more services have become shared over time. So by virtue of that, they've expanded, our ability to access those have expanded because those shared services that were once part of CVMC or part of any of our partner organizations are now located at the network level. So by virtue of that, I think there's been expansion.
Right. That all makes sense to me. So then when I look at the amount of shared services that CVMC pays the network for, it looks like your total dollar amount that you're paying in has actually declined significantly. And I was looking just at FY22, and at that time it was 23.2 million. And I'm looking at the amount before the expense gets netted out. And it's dropped to 16.8 million. So, and that was 6% of the total down to 3.2. Can you talk about why that's changed both in a dollar value and as a percent?
So just as we've become more efficient with local operations here, as a network, we've become more efficient with shared services. So over the last several years, there have been reductions in shared services as we've learned to systematize and optimize those services as well. So the benefit of that is we've seen a reduction in our expense related to those services. And I would imagine that we're going to continue to see improvements in that arena over time as we leverage IT solutions, leverage AI. You heard that earlier, and Dr. Leffler and Judy Picklee's presentation. As we do all that kind of systemization, the cost will come down. It doesn't happen immediately, but it does happen over time. And I think that's part of why you're seeing a reduction. We're seeing a reduction at CVMC.
Okay. Yeah. And I appreciate those examples. Do you have an example specific to what's happened between 22 and 26?
Not off the top of my head. I'm trying to think. It seems like such a long time ago, but I'm sure there are good examples that we can share with you, Member Teachout.
Okay, thanks. So I did want to jump to your 340B. You're assuming lower revenue, and you said, quote, additional manufacturer restrictions. What are you thinking? Because I know that H266 did do some changes to protect your contract pharmacy revenue.
In that space, there's always federal regulations, and manufacturers don't always play by state rules. So that's what we were anticipating at that moment in time.
Do you think it's changed at all since the passage of H66, your sort of outlook on that particular revenue item?
At this moment in time, I'm optimistic.
Yeah, I'm happy to add a little bit to Member Teachout. So yeah, for 26, so there's no doubt that the legislation will help our contract pharmacy arrangements. 26, it'll take a little bit of time, according to our pharmacy team, it'll take a little bit of time to actually see the benefit of that. But when you see our budgets next year in FY27, you'll see hopefully some significant increases in contract pharmacy revenue for all three of the partners. But for this fiscal year, it'll be a little bit muted just because it's going to take some time for all of that to get put into place.
Okay. So you're already seeing the reductions in the revenue because of that, and then now that the new law is going to go into effect. It'll take time for it to reverse. Is that what you're telling me?
Correct. We're still going to continue to see declines in contract pharmacy between now and December, which is
Okay.
we've got three months of our fiscal year is October to December, and once January comes around, that legislation will help. Even that, the light switch is not going to go off on January 1st. It will take some time for that to work its way into our finances. But the hope, as Kim said, is that we will see some benefit in our contract pharmacy revenue.
Okay, so will the benefit be, just to put a finer point on it, a decline, a reduction in the decline, or an increase in revenue? Do you know what I'm asking here?
Yeah, it should really be essentially a stopping of the decline. We've seen the decline over the last 3 years, and the legislation should allow us to recoup some of that decline that we've been experiencing.
Okay, great. Thank you. That's super helpful. And now I want to ask about e-consults, because all across the network budgets, but especially in yours, you talked about the benefit that's having for patients and for opening up access in your system. And I wanted to ask specifically about how these e-consults are billed. Can you talk about that?
I'm going to defer to Kim or one of our network experts in that. That's not my expertise, unfortunately.
Kelly, I saw
Maybe-
you come on. Did you?
Yeah,
wanna-
maybe I'll take a shot at it.
Sonny.
Member teach out.
Sorry, Sonny.
So no worries. So the way that the e-consults work is that when a patient goes in to see their primary care physician, and I'm just going to make it up. Let's say they need to see a rheumatologist, or the primary care physician feels that there's a rheumatologic issue there. The way that the e-consult works is that the primary care physician fills out a form, sends it to the rheumatologist, sort of behind the scenes, with very specific questions and specific components of the history. Then the rheumatologist will look at that. And Brad, please jump in if I'm misspeaking here. But then the rheumatologist looks at that and looks at the assessment, looks at the information that's there. Sometimes we'll have to go back in the chart. This is where, as Anna mentioned, being all on the same system, they can pull out all the information that they need, and then responds to either, here's what we need to assess, diagnose, and or treat without necessarily seeing me. And about 80% of the time, they're able to do that by just sending back that message back to the primary care physician, who can then initiate any one of those steps without having to go see the consult. There is no charge on that. Nothing goes out. Internally, now what we've done is we've created more work for that primary care physician, because before all they had to do was put the consult in, and there's a little more work for the consultant without actually seeing the patient in that space. But on the other side of that, the 20% that they then flag to say, yes, we do need to see this patient, then they expedite that. And so the goal there is that you're seeing patients that actually have real need to see the consultant. Those patients, of course, then get to the consultant and generate the normal legally required charge that goes with that. But then otherwise, in that in-between step, though, in those 80% of successful ones, there's no additional charge that goes out to the payer. Brad,
Well,
I just want to, please just, I just want to make sure that I'm not misspeaking on any component of that, because I don't want you to think that there's something deceptive going on there. There isn't. I just want to make sure, Brad, can you just verify or correct me if I'm wrong? Don't hold back.
Yeah, for sure. And member teach out, I'm going to kind of jump to the end, because tell me if this is not the intent of the question. So e-consults have separate codes that are billable. They're all billed to insurance companies. The fee schedules for those insurance companies are significantly less than what it would be for a full consult. Some data I've looked at is probably 25% to a third of what a consult would actually bill out. So the math behind that, of course, the challenge of how many e-consults can you do, versus how much time it would take to see a patient in person. Does that get to the question a bit?
Yeah, and I kind of was wondering if this counted it as an asynchronous visit or not.
I think internally it's a good question. Internally, we don't count it that way. I mean, we genuinely look at the number of e-consults and then building out, over time, additional e-consults for more and more specialties.
And you also provide this service for independent docs who are not part of your network.
Not yet. We've been working in fits and starts to do that with a few different entities. And some of this F2HCs, the interoperability is a challenge. And so we have 2 organizations we're working with right now to work through that with some manual workarounds, meaning the staff will have to, grab that documentation for the patient from the other record and help move it into the Epic record. So we continue to look for partners, but I want to be really transparent that the lack of interoperability is a challenge.
Okay, great. I appreciate the detail there. And my last question is about the discussion of the CT scans for stroke rule out, and whether or not CVMC is unique in what you're doing, or if this is happening across many facilities.
So in the state of Vermont, I think we're the only community hospital that has that primary stroke center certification. But across the US, organizations that have that certification would see similar utilization rates for CT scan.
Okay, so the additional CT scans you're doing is part of the package of services for this primary stroke center.
It's part of the standard of care for when the patient arrives in our ED as part of the diagnostics, yes.
Okay. And can you, in a little more holistically, talk about how that helps the patient, or how that helps the system, or, something along those lines?
Yeah, definitely. So as I mentioned in my opening remarks, there is lower morbidity and mortality rates with patients that are treated in these type of stroke centers. So there's a pretty rigorous set of criteria that one needs to meet to be designated as a stroke center, a primary stroke center. And we have performance measures that we have to continue to maintain to keep that designation. So we just received that designation late last summer, and we've already had our first review again, not even a year later, to make sure that we're hitting all the metrics that are required to maintain to continue with that certification. So it's an ongoing higher level of standard that we need to meet for this population. And the results for those patients are pretty dramatic. So if you can impact quickly on a patient that has the signs of a stroke, their long-term sequelae are minimized. And obviously with that are better long-term outcomes for that individual patient. So it's something we're really proud of doing, something it's a full team effort. And then obviously we're connected to the UVM Medical Center for that even higher level of stroke care. So we often will stabilize, treat, but if they need more invasive interventions, they would go to UVMMC as a tertiary quaternary care center to provide that level of stroke care. So it's a great partnership, and I think, again, really exemplifies the value of being part of a network.
Great. Thank you. That was all the questions I had. I appreciate the clarifications.
You're welcome.
Member Holmes.
Great, thank you. And thanks for the presentation. And again, like all the work leading up to it. I wanted to start, some of my questions were answered, so thank you for great questions, Member Teachout. I did have some additional questions though. On page 6 of the narrative, you state, as demand for healthcare services increased throughout our region, CVMC's hospital outpatient services will not be able to meet this need in increased volume as we reduce expenses to achieve compliance with GMCB budget guidance for fiscal year 26. Can you explain which specific outpatient service needs you will not be able to meet for your community this year?
Well, I don't know that we specifically are looking at any reductions in outpatient services. I think that might have been a reference to some of the changes we made as part of fiscal year 25 with the consolidation of some of our practices, and both in rehab and primary care. But we're not anticipating specifically any reductions in services.
Okay, so you would say that your budget doesn't include any eliminations of any services? I know
That's
you have
correct.
inpatient psych, but other than that,
Yes.
there's no elimination of services.
That's correct.
And your sense is that the consolidation in rehab and primary care, I think you just mentioned, but that doesn't constitute a reduction in service.
Correct. So we've just moved some of the fixed costs by consolidating. We're optimizing some of the fixed costs in practices that already exist. So we're improving efficiencies as a result of that, but the service should be the same.
Okay. It looked like from the department FTEs, it looked like you're planning 6 fewer clinical FTEs in family medicine. How will that not create a reduction in access to primary care?
So I'm going to defer that question because I don't have the details of those specifics, unfortunately.
Okay. Defer, you mean to somebody else or to another time?
I saw Brad just came on, so he probably has all the detail there. Thanks, Brad.
Yeah, Member Holmes, we can follow up on the specific detail. The methodology behind it is related to the primary care risk-adjusted panel sizes, the overall observed to expected. So I just want to mention that as well, but we can follow up on the specifics of that.
Okay. It also looked like you're reducing staffing in PT from 16 to 11, according to that department FTEs. So it seemed like that would also create a reduction in access to physical therapy in the community.
So thanks for asking that question very specifically, Member Holmes. For our rehabilitation services, there are a number of community providers that exist in our market. And so we've been able to work with them to see if they have opportunity to take on some of those referrals, and they have. And so we have, as we've reduced through attrition some of our rehab services staff, we have not needed to replace them. But and we have reduced from, I think we had 7 rehab practices, we're now down to 4, with some of those therapists coming into those practice sites, again, optimizing the fixed support staff around them. But we also are trying to move services into the community, which I think is one of the goals of our health reform system.
Okay, I just want to be clear though, when I'm asking about a reduction in services, I'm asking about a reduction in services that CVMC is offering, not really thinking about, is there a reduction of services in totality in the community? It sounds like there's some shifting of patients from CVMC potentially to independent PT providers in the community. To me, that would be a reduction in services offered by CVMC. Do you see the difference in how I think about it?
I appreciate your explanation. Thank you.
Okay, so with that understanding of reduction in services in mind, are there any other services that you're anticipating reducing the provision of by CVMC, whether it's going to be offset by independent providers taking that up or not? Is there any other reductions in services we should be aware of?
No.
If we're making adjustments to benchmark calculations for provider transfers, as we just talked about in the UVMMC discussion, should we also adjust for reduced or eliminated services like inpatient psych or PT so that we have a true apples to apples comparison year over year?
I'm sorry, could you repeat that again?
Sure. Yeah, no, I'm thinking about, let's talk about inpatient psych, for example. So we're making adjustments, we make adjustments sometimes when we're calculating benchmarks for provider transfers, right? The assumption is that the care is being delivered somewhere else in the system. When you add a provider onto the books, that care had been delivered somewhere else, right? So that's the rationale for adjusting for provider transfers. I guess what I'm asking in this case is, in the case of reducing or eliminating services like inpatient psych, which was on the books for fiscal year 25, is no longer on the books for fiscal year 26 because those beds are gone. To have a true apples to apples comparison, should we be removing the fiscal year 25 associated NPR from the inpatient psych, for example, to have a true apples to apples comparison of growth in NPR from 25 to 26? Presumably that care is being delivered somewhere else in the system. Those mental health patients are seeking care somewhere else. So that NPR still exists within the system, just not at CVMC any longer.
When we resubmitted our fiscal year 25 budget in November, the NPR was adjusted to take out the impact of the inpatient psych unit as of December 31st. So it
Okay,
had 3 months worth of NPR, which was upside down. Because we were losing money in that service, in that space.
okay. So the NPR from 25, the inpatient, when we look at budget to budget from 25 to 26, the $4 million, I think that's what it was in NPR, but I could be wrong about that. That might be not, my memory is not great on this one. Is that included in your calculation of the growth in budget or not?
We would have backed it out for our 26 start. When we do our budgets, we back stuff out that we know is being pulled out. Just like if we were adding a service, we would be adding to that. I think I'm clear. I'm following your question, Member Holmes.
So I think maybe, so the 25 budget, what I took from what Kim said is that it already included reduced revenue. So the guidance gets applied to the 25 budget to come up to and compares that to the 26 number. So I think there may be 3 months that's missing there, Member Holmes, but I think the vast majority of it has been captured in 25.
If there's any follow-up to that, that would be great, just to make sure that we're apples to apple comparing. I want to ask about expenses a bit, because to meet, again, this is similar to my questions I suspect about UVMMC, and probably the same for Porter. To meet the expense growth target, there's a heavy reliance on reduction in travelers. And I think to meet the budget to budget reduction, or the budget to budget expense target, it requires a reduction of 23 travelers, which is a 26% reduction budget to budget to save $3.4 million. Different than UVM-MC, in 25, you're actually over budget by $3.2 million because of higher than expected traveler use. So when you look at and I think you said in your testimony, it was $3.2 million over 25 budget for travelers. So when we add the two together, the delta that you're anticipating is over $6.8 million or $6.6 million. If my memory is right on what you said the deltas were. I'm really trying to understand, is that realistic? To go from where you are at for 25 projected to where you need to be in 26 to achieve the expense growth target that you're anticipating?
Member Holmes, I would have to get you the detail, but keep in mind our nursing home is part of those numbers as well. And under our new management contract, the hours per patient day ratio with our clinical staff at our nursing home has tightened down what we're needing for our travelers. And we're also looking obviously under the contract, our recruitment efforts to maintain and recruit and retain our existing nursing staff is also at play as well. And then I know we have one respiratory therapist that we've graduated and will be part of our team that was a traveler at one time. And we've also been able to convert an MRI traveler from a traveler to a permanent staff member as well.
Okay, well, any additional follow-up that would help us, you know, understand how feasible this traveler reduction is going to be, and if you need to break out what the, you know, the nursing home is relative to the hospital and what progress you've already made, you know, since this budget was submitted and projected 25 would be really helpful. I also, similar to my question from, you know, to UVMMC, I think the ability to do this depends a lot on culture and, you know, your ability to recruit and retain and convert to permanent. So it'd be really helpful to see those employee, you know, satisfaction surveys to understand, you know, how easy that might be to do. So if you could follow up with that, that would be helpful. And I would just say the same thing for Porter. I won't ask, but it's similar questions. I'm really trying to understand if this is going to be possible. And the same question I would have for you, if you can't achieve the traveler reductions that you hope, and I hope you can make them, but if you can't, where will you find cost savings elsewhere to ensure that you don't compromise access to care?
So I'll start and I'll let others jump in. So there's a significant effort in optimizing clinical efficiency. And that means just looking at the practice that we have and seeing where there's opportunity to reduce costs that doesn't add value to the patient or improve the outcomes. So I think we have some opportunity there. So we're looking at that across the network. And specific to CVMC, we think we might have some opportunity in that regard. But we're going to continue to look at efficiencies across our system. I mean, one of the reasons why we're a lean organization is our staff find those opportunities for improvement. And so we've empowered them to go ahead and make those changes and make those decisions. And we support them in that by removing any barriers that they may have to impacting those changes. So we're going to continue to look to see what we can find to improve both clinical efficiency and operational efficiency. So it'll be on us to really stay on that and make sure we achieve them if we don't meet some of our currently budgeted savings.
Okay, and your commitment then is also not to compromise access to care and not eliminate services.
Correct.
Okay. And my final question is around some of these e-consults. It sounds like there is some wonderful expansion of e-consults, which would save travel time for patients, save cost to the system. And I'm wondering where in the budgets collectively we might see the offsetting reduction in revenue expected from specialists visits.
So you would see that in net patient revenue, member homes.
And it specifically, has it been booked in across all of the hospitals? Is there an anticipated cost savings from each hospital, in each hospital's budget for the reduction in specialty visits associated with the increase in e-consults?
Brad can speak to, I think in terms of savings, I don't know if that's exactly necessarily the term. I don't think that it was approached that way, but Brad and his team did build his budgets based on a certain number of e-consults, a certain number of clinic visits. And so I'm sure over time that ratio has changed so that the impact on net patient revenue is in our budgets. But I'll let Brad expand on that a little bit more.
I don't know if I'm thinking through your question. I don't know if you'll see the direct offset because of the total demand. Recognizing, I think the question is about, tell me if I'm wrong, how the individual provider spends their time, right? So I think it's more of how much are you taking in for e-consults versus how much reimbursement is there for consults? Is that?
No, I think the question is, I think the premise is that if your primary care provider can do an e-consult and save that patient, and this is some fraction of those visits to a specialist no longer need to occur, right? Because of that e-consult, there's some fraction of visits where the information from the specialist back to the primary care prevents a necessary visit. I would expect that we would potentially see a reduction in specialty visits. And so I'm trying to see, to some degree, I'm trying to understand the true magnitude of the cost savings here from e-consults and increasing, or reducing rather the number of specialty visits. So I'm trying to see where it might land in the budgets. Does that make sense?
Yeah, maybe I totally understand your question, Member Holmes, and maybe I'll just throw it in. But Brad and Ramsey, my understanding is that we targeted these areas for specialists that were in such high demand that we were struggling to maintain access for them. And so, I mean, to go back to what Rick was saying, I think you try to do the calculation. The challenge is there's a little more work in the space in between. Work RVUs are not going to go up as a result of that. But what you do get is the folks that are on that waiting list to go see a specialist actually get the answer and go see the specialist. So I don't know if you're the end, I think I used a rheumatologist. If you're the rheumatologist at the end of the day, I think you're seeing just as many patients as you were, minus the effort that you were putting into the e-consult. They're just that the consults are more relevant, that you needed to see them in person. We've served considerably more patients in that time because there's less time. Easier for the patient. I don't know if that actually will, the decrease in revenue to the consultant will be less overall. But if that's going to be really, I mean, maybe you've done the calculation, Brad and Ramsey, I don't know, but if that makes sense. So if you're seeing 20, I'm just going to make it up. Just if you're seeing 20 patients a day as a consultant, and now I'm going to do 5 e-consults and I'm going to see 18 patients a day. There'll be a little decrease, but the point is that we're hitting 23 patients now instead of 20, right? That's the goal is, and I think we really targeted the e-consults, and I see Ramsey's hand is up, so please correct me again. We targeted the e-consults to areas where we just weren't able to deliver the consults that patients were waiting for and our primary care physicians were asking for. And so the goal there was to increase access where we were struggling to be able to deliver access.
Okay, so I guess where then we would see it is in a much higher reduction in wait times for those particular practice areas. We should be seeing that come to fruition between this year and next year as e-consults come online.
Yeah, I think you would see it in,
yeah,
I think that would be a really good measure. So if a primary care physician, if you go to your primary care physician and you needed a rheumatology consult and you were waiting 6 months to get that consultant, you would see a much shorter time period now for those patients that needed it. And I don't know for measuring that again. Yes, if I'm thinking the same way you are, the answer should be yes. And I'll toss it, I don't know the answer, and I'll toss it back to Brad, and I see Ramsey's got his hand up to be able to, but I think you're absolutely right. That would be the logical conclusion.
That's the correct conclusion for sure. If the supply and demand remain the same, and where we've seen where the demand goes up, it's really hard to show in the high level because you don't see the wait times moving. That even though the demand's going up, the wait times are not moving the way we would like them to.
Hopefully the combination of refer backs and e-consults should help that problem, I would hope. Okay, those are my questions. Thank you so much for answering.
Member Holmes, Dr. Harrington's had his hand up for a little bit. So
I'm sorry, I can't see that. Sorry about that.
That's okay. Member Holmes, I wanted to comment on the inpatient psych transfer dollars. I just want to explain clinically what actually happened, because it may help the way you're thinking about this. So when inpatient psychiatry was closing, we knew that that group of patients who were utilizing those beds almost entirely flow through the emergency department. And so we actually employed 2 emergency psychiatrists to provide coverage in the emergency department. And we tacked on some tele support in the evening times. And so it was a change in the service in the emergency department, and mental health challenges, just like I'll use chest pain as an example. When a patient comes and sees us, sometimes we can actually manage that patient in the outpatient setting or in the ambulatory setting rather than admitting them to the inpatient setting. And we knew before the closure that relative to other facilities in the state, the patients that were coming to CVMC were relatively lower acuity. And so the trend that we started seeing is that the mental health patients that were coming in were being seen by emergency psychiatrists in the ED. And with the work that Anna and crew have done with the support services in the county, what we're seeing is that those patients are actually oftentimes not being admitted, where when we had inpatient psych beds open, those patients were much more likely to be admitted. The take-home point of that is, because we had emergency psychiatry services in the ED and community services, I bet when we get a full look at the data, we're going to see that we actually admitted fewer patients and managed them more in the outpatient setting than we would have prior to the closure. And so, are you following what I'm trying to say? Okay, great.
Yep.
And so I'm going to guess that the total expense is going to be less and not fully transferred elsewhere in the system, but there will be some of that, yes.
Okay, no, thank you. That's helpful. Those are my questions, Chair Foster.
Thank you. And just noting the time, we're a little tardy. So Member Walsh, go ahead if you have anything important for CVMC.
Yeah, just a couple of quick things. Thanks for being here this afternoon, and members Teach Out and Holmes asked great questions. I'm just wondering, does your local board independently evaluate the value of shared services in your budget?
Member Walsh, you're asking if CVMC's board independently
Yes.
evaluates?
Yes, that's right.
Not as specifically, but they certainly ask questions about the services we get from the network, and of course, members of our board are also members of network committees and such, so that they have a sense of how shared services works. But if they have any questions, usually it's a conversation with myself, or if needed, which hasn't been needed, the leader of that shared service could also speak with our board. But we have those members come into our board meetings and give updates as part of our board agenda, so they stay pretty relevant with the services that are being provided.
So kind of board to board members, how often are shared services discussed in open board meetings with the public?
So our board meetings are open to the public, but I will be honest and say very rarely do we have public members that join those meetings, but they certainly have the ability to do that. And as I mentioned, routinely on our agenda, we have presentations from network shared service leaders presenting at our local board, so that they get a sense of the services they're providing, initiatives that are underway, and have an open exchange with those leaders related to those specific shared services.
Is there an example from the last year or two where there was a significant budget decision that was approved locally without the network being involved?
Nothing that's coming to mind.
Okay, that's right. Your hospital is carrying the same percentage increase in shared services as UVMMC, 30% higher expenses for high value care, 51 for medical service. You have a smaller operating base and more limited resources. It seems to me like this could function like a regressive tax. If it's heavier to carry, the smaller you are. So how do you evaluate whether the increases crowd out local priorities or stretch your staff capacity, especially in light of your response to Member Holmes? There are services that are decreasing: primary care, the number of FTEs, physical therapy. Are those reductions part of an impact from sending more money out toward shared services?
So our percentage of shared services for CVMC is about 14.2%, I think, of our NPR.
Right, but it's the percent increase. So the percentage increase in shared services is applied equally across facilities. So the high value care aspect of shared services is increasing 30.17% at CVMC, Porter, and UVMMC. So that increase is what I'm worrying about as a regressive feature.
You're correct, Member Walsh. The shared services are allocated on a proportional basis of total revenue. So everybody gets their share based on how much total revenue they contribute to the overall network.
So, I worry at a smaller place that it would leave less money locally to address local needs. But thanks for the answer. That's all I've got. Back to you, Chair Foster.
Okay, thank you. Anything from the healthcare advocate?
Nothing from the healthcare advocate. Thanks, Mr. Chair.
Great. Okay. We'll take a brief 5-minute break and come back at 2:33 for the Porter presentation. Thank you.
All right. Thank you, Chair Foster and members of the board. Good afternoon. I'm Bob Ortmeyer, President for Porter Medical Center and Elizabethtown Community Hospital in New York. I've been with the network now for 4 years as president of Elizabethtown and for Porter in my joint role for the last almost 2 years now. This is going to be a bit of a familiar presentation, similar to last year, as we set the stage to a lot of reorganization here at Porter and through other efficiencies leading to what's been accomplished this year and prepare us really leading into the future. As my colleagues have mentioned, our work this year is focused on delivering high quality care, access, and addressing the rising cost of healthcare. So a couple of things about Porter, critical access hospital, employs 704 people. Of our 123 licensed beds, 25 are the acute care beds, 98 at Helen Porter. Serve a population around 32,000, employ 77 providers, and 206,000 patient care encounters over the course of the year. And this includes 14,000 emergency department visits, which if you're all familiar with our emergency department, it's pretty tight conditions there, very outdated as well. Just wanted to draw something to, I think it's something you hear with all the different hospital presentations as well, of our population here, that 32,000 overall, significantly aging. The overall population is declining by 8% over the next few years, along with the working age population declining by 31%, presenting a pretty significant challenge there. But this will also continue to challenge our access to specialized services as the population ages, as well as stress our already in high demand long-term care environments. Porter has had a financially stable year this year, maintaining our current budget. It was our intent to submit a compliant budget this year with the current budget orders. This, however, was not without its own set of challenges. Many of those issues have already been talked about, so I'm not going to go into a whole lot of detail on them. But significant work has been done this year around quality here at Porter. A gap analysis on the CMS star ratings was performed in September of 24 upon receiving our July of 24 CMS 2-star report. Accurate data collection and reporting were identified as an opportunity for improvement, meaning that some data in the metrics were not accurately reported in the past. Mortality and readmissions were identified as areas of strength, while patient experience and safety of care will be a major area of focus for improvement this year. The quality metrics, according to the star ratings, are monitored for improvement on a monthly basis now at Porter's Quality Improvement Committee, which is also attended and staffed by Porter board members. Porter now has a projected star rating according to CMS of 3 stars for the next reporting period. You move on to the next slide. Thanks. This past year was a great recruiting year, and the Porter community has benefited from this, from new clinicians joining the network and working here in Addison County. This is inclusive of primary care. Their offices are open, with the exception of one right now due to retirement, but don't want to jinx it, but hopefully we'll have a new recruit in there in the fall. In those open offices this year, we've added around 350 new patients into the patient panels, as well as many additional specialists. We've onboarded orthopedics, cardiology, hospitalists, psychiatry, oncology, and several advanced practitioners. In addition to this, there's been a 21% increase, dare I say, in e-consults, about 573 year to date. And this is really getting those patients who really need to get to the specialist in their schedule. And all this is access for our communities. The Community Health Needs Assessment has identified the same high-risk areas for attention this year, which includes access, which we are significantly addressing this year, as well as mental health, substance abuse, and housing. I mentioned our work already around access with the recruitment, and you've heard about the medical groups initiatives earlier. And we partner with the Counseling Services of Addison County for services in our ED, and we've inserted psychiatry into our primary care offices in Middlebury. This year, telepsychiatry is being planned in our emergency department to help expedite dispositions of patients. We continue to explore how we can support our local developers in the housing area, and this is beginning to take shape in the Virgins and Middlebury areas with affordable middle-income housing opportunities beginning to become available. This is vital to attracting and retaining our workforce. You've heard about the work around clinical productivity from the medical group, and that spans into Addison County as well. We are continuing to standardize the ambulatory clinic schedules, standardized scheduling, which allows us to leverage those digital tools you've heard about. We are continuing to meet the ongoing needs of our patients. Actually, meeting the ongoing needs of our patients with appropriate facilities is an ongoing challenge. And we're preparing to begin construction at our Pond Lane facility for combined orthopedic and rehab practice to support the demand, as well as just recently having completed an extensive planning process around an appropriately sized emergency department. The current ED is severely undersized for the 14,000 patients that visit annually. Our work in the post-acute area begins on day one of admission, and initiatives this year have been on case management and a dedicated utilization management resource for Porter, which helps facilitate patient placement at a more appropriate pace, allowing for inpatient admissions to help partner hospitals with capacity. Also, external relationships, such as with Addison County Home Health and Hospice, are allowing patients to get to the right level of care in a more expedited fashion. Although Helen Porter Nursing Facility is not part of the hospital review process formally, I'd be remiss if I didn't mention it's important to the community as the sole long-term care facility in Addison County, which is financially supported by Porter Hospital. Helen Porter is now part of a larger system initiative around a coordinated approach to post-acute care operations and patient placement. This has been successful to date on many levels for patients and staff, as well as reducing the financial loss primarily through traveler reduction and addressing billing processes. There are significant expense pressures that we've been hearing about all day. We have an ongoing review of our processes here to gain efficiencies, whether that's a clinical process or administrative. And we put a particular focus these last 2 years around our administrative services and have reduced the cost by eliminating duplicate roles, at least 10 at this point, with Elizabethtown Hospital, a critical access hospital with adjacent geography to Addison County. I spoke of this last year, and these efficiencies have continued with a shared savings now between the two hospitals of $1.75 million annually. In addition to this work, Porter has reduced its travelers from 44 to 19 currently going into the new year. And in fact, Helen Porter has reduced their travelers from 33 at the start of the fiscal year, and we're down to 9 currently. Porter's reduction was made possible by revising the inpatient nursing structure, which was a shared learning from Elizabethtown. This saved $1.2 million in staffing. And our workforce pipeline partnerships have also helped fill critical positions that would have otherwise been filled with travelers. Our pipeline partnerships have supplied, just to give you some examples here, the following new employees this year. For licensed nursing assistants, we have seven new employees from the Patricia Hannaford Career Center. LPNs, we've employed 3 new LPNs from Vermont Technical. RNs, really good year with our RNs this year. 4 pipeline participants from VTSU and 2 from North Country, and 7 new graduates and 7 new external hires. So a great year of recruitment through our RN program. All these adjustments have allowed for a decrease overall of 42 FTEs in our budget. This is inclusive of some other open positions that we've opted to eliminate, resulting in an annual savings of $4.9 million. These savings have been instrumental in allowing Porter to continue to cover the operating losses of Helen Porter Nursing Facility, again, which is a value community resource here. So really overall, there's no significant changes in volumes or services provided here, but rather continue to look at how we do things that drive efficiency through increased collaborations, either locally, regionally, as well as across our system, resulting in increased access to care for the communities that we serve. So to dive into the numbers a bit more here, I'm going to turn things over to Scott Como, our CFO.
Thank you, Bob. Good afternoon, everybody. Just picking up on Bob's sentiment, my goal in the next few slides is to not only show how we're financially compliant with the guidance issued by the Green Mountain Care Board, but how we're really pushing the efficiencies and the collaboration opportunities that we have within our jurisdiction to reduce cost. And as you'll see in a couple of slides, it's that actual cost reduction that's playing a very big part in bringing this budget together. Next slide, please. So I'll just start with where we are in the current year against the current year plan. And the top level is we're coming in very close according to plan. And our 26 budget is really an extension of that plan. As Bob mentioned, we don't have any new services or any really spikes, no declines in volumes per se. It's really making do with what we have and trying to do as much as we can. So looking at this graphic, the projected volumes against our original budgets, really coming in close to plan, ED visits, medical group, OR. The one anomaly we see on the upside are the MRI and CT scans. And we've intentionally expanded our access to try to decrease wait times, not only at Porter, but at other partner affiliates. So that is something we are incorporating into our budget coming into next year. The other thing I'll just note is at the bottom of the page, our inpatient swing number. While the percentage number is large and the actual numbers are not, it is a very meaningful piece of Porter's not only operation, but financial picture. And so we saw a dip in the last 12 to 16 months of the swing patients that we've had come to our inpatient unit. And we're sorting through it, and a lot of it has to do with us finding our role within the overall case management mix of the network. And as you'll see with our budget in 26, we are expected that swing bed census to rise. But it's an important piece of our business, and not only from a volume perspective, but as I'll touch on in a minute, from our revenue perspective as well. So I'm going to spend a couple minutes on this slide because this is where I think it mostly comes together. And I'll start with the FY25 budget against the 25 projection. So the volume picture that we went through on the previous slide is generating a net patient service revenue projection of about 129 million against a budget of 130 million. So again, coming in really close to plan. The one thing that's not reflected in that volume summary that we just reviewed was we did have to implement a slight decrease in our Medicare payment rate. And this gets into the nuances of being a critical access hospital, because an increase in cost does not equate to an increase in reimbursement from Medicare. And that is something we found out, and it ties back to our swing bed census. That was a big driver in the level of Medicare cost reimbursement that we were allowed, because it is inpatient-based, it is hospital-based, and it didn't materialize to the extent that we were expecting. So the net patient service revenue projection here does reflect a slight decrease in our current Medicare rate, but we are anticipating a bump moving forward. Other revenue is coming in $2.1 million above budget, driven primarily by utilization of our 340B drug program. Salaries is where a lot of our work is happening. And so in the current year, when we started the fiscal year in October, we were in the middle of contract negotiations with a technical and support services union at Porter. And we were not sure where those negotiations were going to end. We did our best to budget our expectations, but we ended up settling at rates slightly higher than we had budgeted. And that is the primary driver for our salary run rate being over the original budget. However, now about 66% of the staff base is unionized, and that adds a lot of stability in our ability to plan and predict salaries in the future. And that really was a tool to our advantage going into budgeting for FY26, because a lot more of what we were committed to there was known. Fringe benefits are slightly under budget in the current year because our staff FTEs are under budget in the current year, and we don't have as much utilization of our health plan and benefits as originally budgeted. The non-salary expenses are coming in very close to plan, doing a lot of great work to manage the puts and takes that happen throughout the course of the year, so that total expenses slightly over original plan of 129 million against a budget of 128. But at the end of the year, we're going to be coming in very close to our original budgeted income of 6.3 million with an expected operating income of 6.2. So things not shaking out exactly the way we originally budgeted them 15 or so months ago, but landing very close according to expectations. So now I'm going to move to the FY26 budget, and specifically as it compares to the FY25 budget, because that is a lot of where our reference points take place. So net patient revenue in FY26 budgeted at 134 million, which is up 4.5 million over the 25 budget, which is the 3.5% budget guidance. There are three major inputs into that net patient revenue growth. There is some incremental volume over our current run rate that I'll get into in the next slide. There are some rate increases included. We do have a 3% commercial rate lift built in, as noted. We also have a 3% increase in our current Medicare reimbursement rate, again, tied to some increased inpatient volume expectations. And I should note that we also have an increase in our bad debt and free care rates, recognizing what's going on today in our community and what might possibly happen in the future. Our free care percentage rate was increased by 0.75%, and also built into our net patient revenue expectations. Other revenue is up year over year, 2.1 million. Again, a continuation of the community utilization of the 340B program. And salaries is where we've done a lot of work. And as you can see, our salary budget for FY26 is 64.8 million, which is $500,000 less than the salary budget for FY25. And that is with significant wage increases built in, which we'll get into on a future slide. So we were able to do that basically with three ways. One was a rate reduction, and the rate reduction comes in the form of the travelers. As we've talked about a lot, just any traveler that you have, the rate for that traveler is coming down. We've also looked at our staffing mix in certain areas and really have staff operating at the highest level of their license, which really allows us to maximize the wage rate that we're getting. And as Bob mentioned, we've continued to experience operational efficiencies working with Elizabethtown. I have more details of this work in the next slide. Year over year, our fringe costs are going up by $900,000. We do expect an increase in our health benefit cost, as well as an increase in our permanent staff FTEs. The non-salary expense increase of almost $3 million. I have that detailed out on a future slide of the inflation drivers there. All adding up to a net income of $9.7 million, forward income of 6.9%, which I recognize is higher than it is today, higher than the budget in the previous year. The rationale for us needing that higher margin is linked to our continued support of Helen Porter Nursing Home. And as I'll get into in a future slide, unfortunately, the Helen Porter Nursing Home operating income is expected to erode year over year. And so to make the overall bottom line work, we had to wring more out of the hospital margin. So next slide. So on that net patient revenue increase, the utilization driver, this speaks to, year over year where some of those volume increases are. Of note, they're very consistent with the run rates that we saw on the projection slide. However, OR cases on this slide are budgeted to increase by 14%. We're currently running at 4% over budget. So this is a slight increase in cases, a lot of work trying to keep Addison County residents closer to home. And we have the OR capacity and provider complement to do it. The other note here is the increase in our average daily census. On the acute side, we are up to a 14 patient average daily census, and we're currently running in the 11 to 12 patient range. And we are also budgeting a swing patient average daily census of 4, and we're averaging closer to 3. And both of those have yet to materialize, but we are in active conversations again with our network partners to create a path to make that happen. We have the capacity to do even more. Sorry, Jake, go back one more. As you can see in FY25, our swing patient budget was an average daily census of 6. So we do have the inpatient capacity to do it. We just need to find the right mix of patient and staffing complement to pull it off. Okay, go ahead, Jay. This is really a summary of some of the inflation assumptions that were built into the numbers that we just covered. On the left-hand side is a rundown of our expense inflation assumptions. Again, there is a slight bit of utilization change built into the budget, but not much. Most of the year-over-year dollar change you're seeing is a result of price changes and cost changes. At the top, you can see we do have a 4.5% increase built into our physician salaries, 3.7% into staff, based primarily on our contract obligations, and a 2.2% increase in traveler rate. But overall, if you move to the right and to the lower right, you can see our FTE assumptions is where the dollars really start to shift. Now, I will say on the physician line, it looks like physician FTEs are going down by 2. We are actually offsetting that with APP providers, and overall, our clinical FTE effort is going up by 1.9 FTEs organization-wide. The staff and the traveler reductions are through some examples that I'll highlight in a future slide. And I was listening to the CMC presentation. So Member Holmes, I will be sure to follow up with some information about the traveler reduction in particular and why we think that that's achievable. So next slide, please, Jay. So a lot of this Bob touched on briefly in his overview, but we did see a 42 increase of FTEs in total across all categories year over year. In particular, contract labor, travelers, 18.9 FTEs or 44.6%, which contributed $2.9 million to the annual spend on travelers. So that was a reduction in cost that's captured. We also had a restructure of how we staff our inpatient unit. This was a great piece of work between our CNO and other CNOs in the network. And really what what it results in is an overall lower level staffing mix with proper oversight. So a decreased reliance on RNs and traveling RNs, more of reliance on LNAs, and an overall 3.4 FTE reduction. So not only an FTE reduction in efficiency, but also how we deliver the work, resulting in a $1.2 million a year savings. And then Bob touched on our continued efficiencies with Elizabethtown. Since we were here last year, we've added a director of laboratory to that list of shared leadership positions and a director of pharmacy services to that list of shared leadership positions, continuing to look for opportunities to bring the two organizations together through attrition or otherwise. So in this summary on the left, really calling out the Porter Hospital margin budget request in context with the Helen Porter budget margin for FY26. The driver of the erosion of the Helen Porter margin is really the lack of presence of EFR in the FY26 budget. Guidance given from the long-term care leadership through correspondence with DEVA was that EFR was not a surety for FY26, so we did not build that into the budget, which led to that margin erosion. Overall, our FY26 has a combined margin of 3.3%. It boosted our days cash on hand back to 110, which is still fairly meager, but as Bob mentioned, we have our eyes on an investment in an emergency department at some point in the future. When I look at our budget, and I just want to call out a couple of identified risks, we spent time with the with UVMMC and CVMC talking about their response to Act 55. We did not build any response to Act 55 into our budget. As Kelly Champney described, we took the work on as a network, looking at where it was going to have the biggest impact first. The impact of Porter is going to be between $2.5 and $3 million a year. We do know that. And we do think we do have some opportunities to make up for that in NPR, and we will be fully compliant when that goes into effect on January 1st, and we will not be increasing rates or prices in other areas to offset it. What we do have as an opportunity, one I mentioned earlier, I think we have increased opportunity in our inpatient daily census, both on the acute and swing side. And we also have identified some potential opportunity in our operating room to keep more Addison patients closer, Addison County patients closer to home, and pediatric, dental, and ENT services. So we are confident we have an opportunity to make up for that NPR reduction. We just had run out of time to build it into the submission for the Green Mountain Care Board. And the other thing I'll call out as just a risk, because I don't think it's thought of a risk much when people think about critical access hospitals, and that is your Medicare reimbursement rate. As we learned with this most recent rate reduction, is that it's more than just your level of costs going up. If only it were that easy. But it's also related to, Medicare as a percentage of your overall business, and the allowability of the cost that you're incurring, because all costs that an organization incurs are not subject to reimbursement from Medicare. So there's a lot that goes into it. We think we've got it figured out and directionally appropriate, but I would just call that rate increase out as a potential risk. Next slide. Okay. I think in closing, we just want to reiterate again, like the other partner hospitals, our budget was submitted in compliance with the Green Mountain Care Board guidance. But what I hope that Bob and I were able to show is that we've taken a step further than that and really taking on the mandates that we heard last year about looking for efficiencies and the cost reductions that come with being part of a network. And I'm proud to say that we've been able to demonstrate that in the budget we put in front of you. So
Thank you. I'll turn to Member Merman for any questions you may have.
Yeah, great. Thank you. I first wanted to start with a comment on a component of your submission and your presentation that I think is really interesting, and is the you mentioned how you have improvement in workforce retention or reinforcement of workforce retention through the formation of the staff and technical professionals bargaining unit. And I think it's really interesting. It's great to hear the strong relationship between the hospital and the union with the intent of improving sustainability at the hospital, sustainable staffing and workforce retention. So I think that's great. On page 7 of your submission, you say that contract labor / traveler FTEs are expected to exceed budget for 25, leading to 2.2 million in additional salary expenses related to travelers. I don't remember hearing that in the presentation. Is that accurate, that in 25 your contract labor is exceeding budget by $2.2 million? Your travelers?
That is true.
Okay.
And we do have milestones identified to turn traveler number over and convert to full-time staff, and that will be part of the information that we share subsequent in line with what Member Holmes was asking about.
Okay, but so from 25 budget to 25 actual, you're up 2.2 million, but from 25 budget to 26 budget, you're trying to go down 2.9 million. So you've got a big drop from 5.1 million in traveler expense to go from where you are now to where you want to be by through the FY26 budget, right?
Correct.
Yeah, Member Merman, I can just add on that the reduction that I mentioned to Helen Porter has already occurred in their travelers already. So those have already dropped. And the inpatient traveler reduction, actually that process has started in July. And between July and October 1st, at the start of our budget year, we should be down to our projected traveler decrease, as I had mentioned, through all the different hires. So contracts have been canceled. They all have to run themselves out. So there is a runway for this, and we feel very confident we're going to hit those.
Okay, so by October 1st, you're expecting to be at this 26 budget level?
We expect to be where we have budgeted, yes.
At the 19, what are it, 19, or I lost my page on the travelers, but okay. So the reduction is occurring, even though you're 2.2 million over in 25,
yes, we feel confident we will be at our staffing levels. Yes. Yep.
Okay. That will be impressive, and we will be interested to know what happens. All right. Just to clarify, though, you mentioned Helen Porter. Is that 5.1 million swing inclusive of Helen Porter travelers as well as Porter Hospital travelers?
The number in the slide that we presented was only the hospital piece of that. There is a conversion with graduations of recent classes to get rid of travelers, and it's impacting both the hospital and Helen Porter.
Okay, but that 5.1 million swing, that's just within Porter Hospital, not within Helen Porter.
Correct.
Okay. All right. And then trying to understand the relationship between Helen Porter and Porter Hospital is a little tricky, because I think, we think of Porter Medical Center, but the way we regulate is different than the last hospital, which I recused from, I believe, is combined. So do you oversee both, though, as Porter Medical Center CEO and CFO?
Yes.
Okay. Is there any allocation of your compensation to each of the organizations, or is it all paid out of one or the other?
There is an allocation. Yeah, there is allocation of both Bob and my time to Helen Porter.
Okay. And does Helen Porter pay for any expenses at Porter Hospital?
No.
And does Porter Hospital pay for any expenses at Helen Porter?
Other than subsidizing the bottom line, that's pretty much, that's our contribution to their
through the margin. Okay. So I was looking at, our staff did a really nice job and took the audited financials to look a little bit at Helen Porter. And it looks like, you've been struggling with these losses at Helen Porter for a long period of time, but really pronounced starting in FY22. Prior to that, maybe averaging $2 million a year, and since then closer to $5 million a year. Would you just briefly describe the drivers of those losses?
Okay, I'll take a shot. It really started during COVID, and the impact that had on their ability to take on patients, not only take patients on, but staff up to take patients. And really, it's been recovery mode since then. I came to the organization in 2023, so I was kind of came into the middle of this. But I know since that time, we've had senior leadership turnover, and we've kind of reorganized the way that we are looking at long-term care across the network in response to this turn of events. So it was, I can't put my finger on a particular thing, Member Merman. Honestly, it just has been a conflation of a decrease in census, and the rate that they were paying for staff and travelers really took its toll for a 2 to 3 year run rate.
Okay. And it looks like in 24, Helen Porter had a loss of about 5.1, 5.2 million. And what I think I saw this year, you're projecting a loss of 4.6 million. Is that correct?
Yeah.
Okay. And in 24, I think I see that Porter Hospital had a 5% operating margin. And this year you're hoping to get a 6.9% operating margin.
In FY26, yes.
Yeah, it's 26. Thank you. Okay. One other thing in the narrative that's kind of tricky for me is this admin to clinical ratio section. When you didn't calculate the ratio, so when I calculate it though, it's pretty high. One of the highest I've seen. Can you discuss why you think that's the case?
I don't have that chart in front of me. Member Merman, do you happen to have it to pull it up?
I have it in paper. It's page 16.
Of the narrative.
How about I send you that in follow-up, and then we can talk about that and keep moving here.
Right.
When you talk about 323 patients added to primary care, is that a net increase to the primary care panel at Porter?
That's my understanding, yes.
Okay. Are there any new primary care providers that joined in 25? Well,
Yes, there are new primary care physicians. Yes, there are.
Okay. It's a pretty modest increase for if you've hired anybody. I mean, a typical primary care panel, I don't know, do you know what your panel size is at Porter typically?
I can defer to Brad on that one.
The average across the network is about 1150 for physicians.
Okay. So I think I would look forward to higher access, but I think that makes sense because it looks like you're predicting to increase your work RVUs for physicians and primary care providers in the outpatient setting. So that's optimistic. Response to board question number 4, this is discussion about this pediatric dental potentially coming to Porter. It sounds like an interesting scenario. Losing revenue from Act 55 has basically made more space under your revenue cap to allow you to provide more services. What other services do you think you would like to provide at Porter if you had space under your revenue cap to provide more services?
Yeah, so obviously any type of ambulatory access that we could provide, we would want to do. So I'd want to look at some additional specialties, whether or not we could, recruit additional dermatologists, which we used to have here in the community. Endocrinology would be great to have. Give me a wish list of specialists, and I'll give you a list. I think there's always efficiencies we can gain through our OR. That's where our pediatric dental cases would be done. So if that comes to fruition, if we're able to help the medical center decant some less acute services from the medical center to make room for the sicker patients there, we'll certainly do that. So I'd say the list is long, that we could, try and do that. And I see Ramsey came on camera here. You may have something to add here, but.
Yeah, I guess in the projected numbers, we already have some orthopedic volume, so we're expanding services there. We're looking to potentially expand some of our non-invasive cardiology testing down at Porter, which would be great. Porter's anesthesiologists will do pediatric patients, and so that opportunity for the pediatric dental was noted. And we've got an opportunity to expand some ENT coverage, some subspecialty coverage down there if OR space is available. But we're thinking broadly about what we can do for that community.
Great. Thanks, Randy. Let me just go through the rest of my things here. I'm trying to keep us moving fairly quickly. Okay, so there's some funny things. The primary, we talked about the top 5 margin, high margin services and low margin services. I don't know if you guys take a look at that, but primary care is listed in both the high and the low. Just want to sort of point out that it looks like it was low in one year and then high in the next couple of years. Do you know what changed to move it from low to high margin?
I don't, but I know that, I think the network's way of pulling the data was a little unique in that it attributed all services back to a discharge provider. But what might have changed in the data to cause that service to switch year over year, I can't explain that.
Okay. Since we're talking about kind of the attributing to provider, there's some of the RVU data is a little strange too. You have 1.3 APPs in your ED that earn an average of 10,500 RVUs per FTE. So I assume there's something going on with the RVU data. Can you give any explanation for what's going on in the RVU data?
Not at that level, I don't.
Dave,
Yeah.
sorry, Member Merman.
Yeah.
Let me take a shot at that.
All right.
So in the ED there, they have single coverage MD with a single PA every day. The volumes are fairly high. And so the PAs are seeing a lot of patients independently. So they're doing their own primary billing. They're seeing a fair amount of patients, meaning a relatively high patients per hour. And importantly, they're also doing all the minor procedures. And so historically, the PA position that's at the Porter ED has fairly high WRVU data. That is purely the clinical perspective that would make that number make sense to me. Nothing more. I have not, dived down into that specific number.
It has there's some funny things in there where there's a few that are super high and a few that are super low that don't seem to make sense from a clinical standpoint. So I wonder if there's like a data issue there. I mean, for instance, the cardiology group is very high RVU generating, but is listed in the lowest 5 margin services. I would think that cardiology generates a reasonable margin if they're high RVU generating. So there's a lot of inconsistencies in the RVU data, and then looking at those compared to the margin data. So, okay. One other area of curiosity I had was that you're predicting pretty substantial increases in CT and MRI utilization, 16%, and attributing that to the high ED utilization, but the ED utilization is only up by 4%. So just wondering if you could try to square that one as well.
Yeah, we've also expanded hours of operation, and that happened in the current year. So that's also contributing, eating to the backlog and reducing the wait times. So that's also boosting the current run rate.
Okay. And my last question was this budget reviewed and approved by the local board of Porter Medical Center?
It was reviewed with them, yes. And then it goes to the network board for approval.
Okay, so the local board doesn't approve it, they just review it.
Correct.
That's all I have for now. Thanks.
Good afternoon. A quick question. On the balance sheet that was provided to us, it shows $30 million due from related parties to Porter. And the fiscal year 24 audited financials showed zero. I was hoping you could describe for us what that $30 million relates to.
That $30 million relates to the due from Helen Porter. I'm not familiar with the audited statement you're referencing, which would have that at zero. We have not changed our accounting treatment of that. So I'd have to follow up with that discrepancy. But on the balance sheet that we submitted, I know that that $30 million represents that due from.
Chair Foster, the zero on the balance sheet, is that a network balance sheet that you're looking at there, or?
Yeah, it's a fiscal year 24. It's a September 2024 network audited financials has zero due from to Porter Medical Center.
That goes back to the way that we need to treat our accounting being a consolidated entry that's an obligated group. All of those due froms when we produce our audited balance sheet, which the auditors require us to do, nets all the due tos and due froms against each other. So when you look at the network balance sheet, it's a zero.
Oh no, sorry, it's the consolidated balance sheet. It's page 67. It's a UVM Medical Center obligated group consolidating balance sheet, and it lists each of your hospitals and the network, and it shows the Porter owed $30 million.
Yeah, so if you're looking at the balance sheet that has columns for each of the individual hospitals, and then there's a column that has eliminations.
Yeah.
That elimination essentially nets all of those due froms down to zero.
No, I understand that. I'm asking where the money's going to, and I guess the answer was to Helen Porter.
It sounds like that. Yeah.
Yeah.
Okay. Is the entirety of the $30 million that's due from to Porter from Helen Porter?
It is.
And again, same question. Why was it zero in September 30, 2024?
That I would need to see the schedule you're referencing, because I'm not sure why it would be.
Okay. It's on your website. It's the audited fiscal year 24 financials. If you want to reference it, page 67. Okay. I had no other questions. Other board members?
This is Sarah. I have one question. On page 7 of your narrative, you talk about denials, and you say that due to your improved registration and prior authorization processes, denials in 25 are expected to be below budget. Can you talk about what you improved to get the denials down?
There are two things that, yeah, just want to make sure I was not on mute. There are two things that come to mind in particular. One is a focus on our pre-registration efforts, and so that we have the demographic and payer information for patients correct when they present for services. I know that's been a big push, and we've been able to pre-register more patients than we have historically. And then the other thing I would point to is an increased focus on prior authorization and prior authorization denials, if we happen to get them, following up, getting the paperwork that we need. But that's been a concerted effort, and they've been, the efforts have been paying off. So those are the trends that we've started to see tip that we are hoping to continue.
That was my question. Thank you.
Any other board questions?
None for me, Chair Foster.
Healthcare advocate?
No questions from the healthcare advocate. Thank you.
Okay. It's 3:20. Why don't we take a 15-minute break and we'll come back for the network at 3:37. And I anticipate we'll go over time, but I don't anticipate going past 6:30. We'll try and keep it relatively close. Does that work for you all, or would you rather book a second day or part of the second day?
No, I think we'd rather finish it today.
Okay, let's do that. We'll try and keep it snappy. So we'll take 15 minutes and come back and we can take a recess. Thank you. All right, so we have some time to ask more questions about the health network and how this all interconnects through the network operations. A couple questions I had. First, does the health network track the use of shared services by each network member?
Rick?
So we track shared services in totality, but each member does contribute some cost to shared services. So we have two in our budgets. You'll see two different lines in there. You'll see a shared service credit line. And what that is that's the contribution that partner is making to the overall shared service costs. So just using an example, there are employed IT members at the UVM Medical Center that actually are, since IT is a shared service, are providing services to the entire network. The UVM Medical Center gets a credit for those IT costs that they're contributing to shared services. So you see that represented in that shared service credit line. And then their overall allocation of shared services based on total revenue you see come through on the shared service charge line.
And my question relates to the use of shared services.
Yeah, I think I know where you're going, Chair Porter, on Foster, on that. I think on any given day, on any given time, any given month, and I saw a little bit of it from what Anna was saying and Bob was saying and Steve was saying, is that certain organizations are going to need shared services more or less. I don't think we have that level of detail where we're tracking it. It's like a year to year kind of thing. So there may be when there's a union contract negotiation that is going on in a particular organization, there may be legal services that are committed and spending more time in that year with that organization. But I don't think we're allocating or accounting at that level. It's that larger piece of how we allocate costs. And then I think as Steve Leffler referred to, there's an ongoing, we think a healthy, honestly, dialogue around, hey, we think we need this service that comes from IT, and we're not getting enough of that. And we need more of it here. And other people may argue, well, we don't really care about that, but what we really need from IT is this. And so we try to bring those groups together in making determinations about what we're going to do in those shared service areas. And that's, of course, part of our challenge as we align and integrate to make these difficult decisions about different, I'll use IT here, different IT services that may exist at different organizations. And our goal is to say, yes, you may not be able to continue to get that, but we're going to give you this because across the board, this is going to bring us greater savings. And a couple of you will have to change, and a couple of you, will have to help us and teach the others why this particular IT service is better than the one that you're using. And we're going to save money overall across the whole system by doing that. So there's a lot of that goes on that doesn't necessarily, day by day get allocated that I can tell. And please, I'm going to transparently share where I see things. And I expect Rick and Ramsey and others to come in and correct me if I'm wrong. And I'll just put that out there transparently. But that's the way that I've seen it operating in the last couple of years. And as we're trying to integrate and align to be more unified, that's, I think, where we have opportunities, because I think we see systems that we can pull together more tightly and get shared savings as a result of that.
Okay, my question, is there any tracking of how much utilization of the shared services each network member hospital uses? It sounds like the answer is no.
No.
We have the shared services file that you submitted. Thank you for providing that. Are there any expenses associated with the health network entity aside from those reflected in the shared services document?
There shouldn't be. We've captured pretty much everything in that document. We even include other non-administrative costs. So we include depreciation, interest expense. There shouldn't be anything else that's network related that's not captured in that document.
Okay. And so this maybe is a colloquial way of saying it, but the health network budget is at $496.8 million. Is that accurate?
It is.
Okay. And in 2022, the health network total budget was $335 million. And I was wondering if you could explain the increase from 2022 to the 2026 budget from 335 to 496.
Yes, we can break that down. A part of that is when the question came up earlier about, you asked about transfers. So every year we do add additional, or we have been adding additional expenses to shared services. So part of that increase is transfers into shared services. I can even, if you're interested, we have a slide, not knowing exactly where we were going to go with the health network portion of this discussion. So just as an example, in fiscal year 26, so from the 25 budget to the 26 budget, we added $7.5 million worth of shared service costs that were transfers from hospital budgets into shared services, because that $7.5 million needed to be allocated to the entire network.
How much of the increase from 335 million in 2022 to the 496.8 million in 2026 is due to transfers?
We'll have to get you that detail, Chair Foster.
Okay. And are there still services that overlap with the shared services at network hospitals? So for example, you mentioned IT. Does MC still have IT, and then you have IT at the network as well?
No, the major shared services, so IT, HR, revenue cycle, those are pretty much all at the network. There are some smaller facilities related costs, employee health, and some other administrative costs that we do still have a little bit of that at the partner hospitals. It hasn't been completely consolidated at the network.
Okay, so what I'm trying to see is the apples to apples entirety of the network and member hospitals FTEs and expenses relating to these shared services. Can you provide that? We don't have that yet, do we?
I don't know exactly what Matt does have, but we can provide multiple crosswalks for you, Chair Foster, to even over the course of 3-4 years, whatever you would like to see, so that you can see exactly what has been true growth and what has been transfers into shared services.
Yeah, that would be great. That's exactly what we're looking for, is the true growth. And I think what we have is from 2022 to 2026. So that would be the time period I think most relevant. Do you know the compound annual growth rate of the network operations, setting aside the transfers?
Again, we'll have to get, I mean, looking at the total number with those transfers in there. I can show you actually one of the, are you okay if I put up a slide real quick, or would you prefer not?
Yeah, no, please. That'd be great.
So this is just to highlight the impact to shared services that actually were part of my one of my opening remarks and one of the stats I quoted. So looking at shared services back in 2022, so administrative shared services back in 2022, when you apply just the inflation factor to that 22 number, we'd be at $419 million for administrative shared services in the 26 budget, and our actual budget is 396. So there's that compounding when you take out the transfers. I suspect, again, we'll get you the detail, but I suspect we'll see very little growth from that time period.
Dr. Merman?
Yeah, was that just for the Vermont hospitals? Or is that the whole network?
No, that was the whole network, but just to clarify, because I know there's, we spent some time with Matt and the team this week. There's two components to shared services. So there's administrative shared services, which that number is a number that we can benchmark against because it includes all of those core shared services. It includes IT, HR, revenue cycle, communications, network operations, that sort of thing. That's the largest piece of what you see in shared services. But then there's another piece of shared services that includes any of the interest expense on the debt that the health network owns. So the debt that isn't specific to any particular partner. It includes depreciation for assets that the network owns. It includes the costs for the share of the department chairs. So both components make up the total shared service number that you see on the budgets for the hospitals when you're looking at that budget line in the budgets that you've been reviewing the last month or so.
Okay. And I want to get a little bit more of an understanding of some of the actual shared services and what they are. Finance administration, can you describe what finance administration does?
So that area has accounting, payroll, analysis, accounts payable, and a few other finance related areas. It also includes, we include in that category, we've got two contracts where we're paying a contingency fee for some work in terms of our Medicare status, GME revenues. So there is, in addition to just traditional shared services or those finance related shared services, there are a few other related expenses that we put into that finance admin category.
Is that reflected when I say the shared services document, I give you the title of the document is the UVMMC Network Shared Services Excel file. And for finance and admin, it's 34 million in 25 and 34.7 in 26. Is that contingency fee reflected in that file?
Actually, I don't mean to be trouble here, but is there any way that we can pull that up? I just want to make sure we're looking at that I can see the number.
No trouble at all. Kristen or Abby, could you pull that up? It's on our website. It's UVMMC Network Shared Services.
Yes, give me a second.
Okay. Mr. Vincent, while Kristen's pulling that up, who is the contingency fee paid to?
I believe it is. Actually, well, I'll have to get back to Chair Foster. I thought I knew who it was, but I'm not 100% sure.
Is that some sort of contractor that assisted with the Medicare status and the GME submissions?
Correct.
What percentage of the additional payment that UVM received was paid out to the consulting firm?
We can get you that detail as well. We'll give you the name and the percentage that we paid for that.
Okay. And then on finance administration, the FTEs went up 9 year over year. Were any of those transfers from network hospitals?
I suspect they were, but we can get you a firm answer on that.
Okay. And then Health Network DEI, I assume, is diversity, equity, inclusion. Could you describe what that group does?
Sonny, I don't know if you want to take that one.
Sure. So they're also a network service across the system, and they have, I would say, 3 really big goals in what they're trying to do. One is in the way we deliver care and trying to ensure that we deliver it equitably, and that we know that we have concerns around the way we deliver care, as all systems do, around if we're doing it equitably or not. We also know that if you're in a poor zip code in any of our health system service areas, that you're going to have a lower mammogram rate, a lower colonoscopy rate. Your hemoglobin A1C, if you have diabetes, will be higher. And so one big function is, what are the things that we can do system-wide to ensure health equity is continuing to improve? 2 is in the way that we collect information to ensure, in that same piece, to ensure that we're actually capturing both real data, that is race, ethnicity, and language data, as well as SOGI data, sexual orientation, gender identity data, because we know that those groups do not do as well overall in health equity. Internally, inside of the organization, that group is also responsible for ensuring that our hiring practices are equitable in every way, and that we don't bring in preconceived biases and notions when we're hiring, and the way we treat our employees, and the way that we look at our employment engagement surveys, and making sure that we all those underrepresented groups feel like they're fairly represented, and that they have a voice here, and that they feel included in the work that we're doing here. And so I think if we look at that, that's probably the largest part of the work that they're doing to ensure that because part of what I always say, and I think what we try to do, is that we're delivering high quality, equitable care, accessible care, affordable care to our communities. And so that's the portion that they're playing.
Do you have a mechanism to track the improvement in delivering care equitably?
We do. So we have year to year, at least since I've been here, looking at specific factors and how we do in that space. So some of those things I mentioned are part of that. So it's the challenge that we have is that number one, so yes, the answer is yes, we do. And so we're trying to look at those factors and seeing if we can drive improvement in that space, driven largely by zip codes, but we're doing that work right now.
Great. If you don't mind, I'm curious to see it. It could be a really interesting model for other hospitals. If you could send me the factors that you look at in evaluating the improvements in that, I think it would be beneficial.
Sure.
External relations, what is that and what do they do?
So external relations are the factor of communicating outside of our organization and the messages that we sent out. It could be anything from the way that our website puts out information for our patients to be able to understand what services are where. It could be the way that we communicate changes or information. It could be the way that it is the way that, all these things, I shouldn't say it could, it is the way that we interact with the media for media related issues. It's the way that we interact with our government officials, and external could also include any lobbying services that we employ. There's probably more in there, but off the top of my head, I think those are some of the factors there.
And in that bucket, in this budget, it's going up 6 FTEs. Can you explain why that's increasing by 6 FTEs?
I would have to get back to you. I'm going to go back to it that the most likely reason is that we've transferred from what was sitting in a hospital budget into the network. I'll get back to you on the detail on that.
Okay. And are there any additional expenditures on outside third parties relating to this external relations bucket, such as consultants, contractors, lobbyists, marketers?
Sure, I'm sure that they are. For example, we outsourced a number of employees for our website and website management. So whenever we don't have the internal resource to do it and we need it short term, we use external forces. So I'm sure that there's a number of them. We can supply a list and the dollars associated with them.
That'd be great. Yeah. Do you know how much the external spend is in external relations?
I'm not sure what you mean by external spend. The dollars that leave the system?
No, spending on outside contractors, consultants, lobbyists, marketers.
No, I don't know what portion of that expense actually goes out to consultants or external folks. We'll give you that same level of detail. Unless Rick, do you know those numbers already, or?
No, we'll provide that detail.
Mr. Vincent, is the number that is reflected on the shared services document, does that include the external spend, or is that just the internal expenses?
No, that would include the external spend as well.
Okay. Kristen, do you have that document available by chance? Oh, you do. Okay. Yeah, so let's go. Okay, external relations. So the total expense is 9.1 million for 2026 budget. And then you've got $5.4 million in management and all other salaries, leaving about a little under $4 million. So is that, what's the remainder of that 4 million go to?
So that again, that must be the external spend, but we'll get you that detail.
Okay. And then Kristen, if you can just scroll up to the finance and financial administration. Sorry, I didn't get it. What is it called again? Yeah, finance administration, line 14. Yep. And so, Mr. Vincent, my question here, you wanted to see the document, whether or not that contingency fee is reflected in this document. Does this help refresh your memory? And if not, you can get back to me.
It does. Yeah, the total expense line on all these is all expenses. So it looks like it was a breakdown of providing. So of the 34 million, for example, in the last year's budget, 20 million of that is personnel related expenses, with the rest being non-personnel, which contingency fee would be in there. Any systems that we're paying for, outside consulting, those types of things would all be the difference between the total expense and these salary numbers that you're seeing for each one of the shared services.
Okay, thank you. And then I wrote this number down, it may be off, but I thought during the UVMMC presentation, there was reference to several thousand people waiting for a colonoscopy. Does that sound correct?
Not ringing a bell for me.
I don't remember that.
I'm on that. That's correct, Chair Foster.
Okay.
About 3,000.
Okay. Yeah. Okay. I was wondering what steps the network is doing to move those patients waiting for a colonoscopy to another site of care.
My understanding, Chair Foster, is that people call in for the colonoscopies. They're offered multiple sites to get them. They can choose to stay close to home, which might take longer, or choose a different site. I know Brad and Ramsey are still on, but my understanding is when you call now, you're offered more than one location.
Okay. More than one UVM location or just another UVM location?
I believe because we're scheduling them as UVM locations, health network locations. We're not scheduling for the private providers doing that.
Yeah, not scheduling, but providing the option or recommending people to go somewhere outside of the network. Does that happen?
I know that at times our primary care providers will refer people outside the network if there's someone needs something timely that for some reason the network can't deliver. I don't believe the schedulers are doing that, but I know our primary care docs do that at times.
I think there are certain services, and Ramsey's going to come out. I think there's certain services, Chair Foster, that people know. I mean, I think aesthetic dermatology is an example where I think the norm is to refer outside because they know what our capacity is. The only other thing I'd mention, and Steve, you can comment, and maybe Ramsey on this, is that we know that we have this issue with colonoscopies, that it's difficult to find places to schedule them. We've actually taken a move to do the FIT tests as well, so that for patients that qualify, that we will use alternative testing that we do have accessible, and it's lower cost to do it. So I know that we've made a concerted effort, understanding that this is an issue all across the state. So that's another piece that's really important to just, we're looking for alternatives. We're looking to try to do the things that we can for our patients. Even the scheduling piece is a relatively new thing, to be able to use the technology that we have to open up and see what's available and where. But you're right, inside of our, you heard it, I think, at both CVMC and Porter, that we are challenged with gastroenterologists, and then challenged with just, our goal is continue to maintain access in that space. Ramsey, were you going to add something?
I was just going to add that the backlog, of course, has been challenged by us not having enough employed gastroenterologists to hit that backlog. And the strategy, I really think, as we look forward, is to optimize the number of people that are getting non-invasive testing there and screening off of the FIT test. But you hit that already, Sunny.
Well, so, UVM is very expensive on colonoscopies. 3,000 people backed up is a lot. That's people who, let's hope none of them have cancer, but it seems like it's an opportunity to move them to other sites of care outside of UVM Health Network. We are trying to drive down and move out care from hospitals to lower sites. So I would put that in, just a flag that this is a goal for the state. We don't want 3,000 people waiting, and we don't want them paying UVM's prices. So perhaps we can use some of the advertising dollars or some of the PHSO work to move some of those patients. I know many people are able to get in pretty quickly at Green Mountain Surgery Center and other facilities. And overall, for affordability and sustainability of our system, that's something that I think we should be evaluating, not just keeping it within the network. And it probably applies to many other tests and screenings as well. So I want to flag that as an opportunity to drive down costs and revenue. UVM HN administration, I think I know what this is. It's line, Chris, let me get it for you. Oh, sorry, Health Network Administration, line 157. And Chris, I think if you make C and D a little bigger, we can see the numbers. Could you describe for us what that is?
So that's all the senior team here at the network. It also includes, again, you can see on all of these, there's going to be a difference between the total cost and the FTEs or salaries. So this cost center also includes charitable contributions that we make, includes corporate memberships. For example, it includes the contribution that we're making to AHEC to help with recruitment and retention of physicians in Vermont. And I believe it also includes if I'm not mistaken, I think it also includes the academic support payments is the other big difference between the 27 million and the salaries that you see there.
It looks like from fiscal year 25 to 26, there's been no reduction in health network administration or external relations, and I was curious why.
I think we have to go back, certainly for external relations, and look at the transfers from our organization and the movement there. I know, for example, philanthropy moved into external relations last year. That might have been a chunk of employees. From our health network administration, again, I think we'd have to go back and give you the detail on each individual. I don't know if you have that accessible, Rick, but.
No, we can. I think the detail will provide some light on what's been a transfer and what's been increasing, Chair Foster.
Okay. And philanthropy, is that on this recorded as health network development?
It is, yep.
So a separate bucket from external relations reflected on this sheet?
Correct.
Sorry, my mistake.
No, that's okay. I just want to make sure I've got the right terms so I follow. Expense reductions. There's been some press, and I spoke with a couple of you, I think maybe before the press was announced, about some of the expense reductions. And in fiscal year 25, there was expense reductions taken too in response to the board orders, closing Mad River, transferring transplant to Dartmouth. And I want to know the total amount of expense reduction associated with the fiscal year 25 budget.
In terms of administrative and clinical reductions?
Yes, please.
So we'll get back to you on both of those numbers. They've been a component of all the presentations today, but we'll itemize that we'll put it all together in a summary for you.
Okay. Do you know directionally how much expense reduction occurred in fiscal year 25?
On 25, I apologize. I thought you were talking about 26. So no, we'll have to get back to you on exactly where that's at year to date.
Okay. And then fiscal year 26, I see in the submission for UVMMC, it's page 4, 19 million travelers, 9.5 purchase services, et cetera. And can you give me the total expense reduction across the network for fiscal year 26?
We'll get back to you on that, Chair Foster.
And I understand there's 146 positions, 77 existing, I think 69 open. And I was trying to find where I would find these positions being removed. Would that be on shared services, or where would I find them?
The majority would be on shared services, and we can create a crosswalk to show you where you see that in the budgets.
Okay. And you don't need to give me the exact number for purposes of discussion, but approximately what is the total dollar value of the expense reductions in the UVMMC fiscal year 26 budget?
So it would be pretty much those items that were flagged on that slide. Actually, I think you were just quoting the numbers there, Chair Foster. The clinical cost reductions, administrative cost reductions in the travelers would be, I believe, the total, but Judy, I think, is still on if she wants to augment that at all.
It looks about.
Apologies, I was on mute.
Go ahead, Ms. Peakley.
Yes, I'm just going back to that slide component for our expense reduction that we had put in. So apologies for
what 4 and
that.
5, 4 and 5 of the narrative as well.
Okay. And I apologize, I just tend not to quote numbers off of the top of my head. There's a lot of them.
Good habit for a CFO.
Thank you. Right. So you can see the areas in our expense reduction are primarily focused on Our traveler expense, which when you net it down was the about the 8.5 that I mentioned, because we are replacing travelers, not a one-for-one basis, but replacing travelers with our employed staff, primarily in nursing. Purchase services reduction, I'd have to get the detail of that for you. The expense reductions that are flowing through, remembering that the health network does flow through the entity for UVMC. So there's the 4.5 related directly to software IT. And then when we look at budget to budget administrative type expenses from areas that in our rev cycle and other areas that we have been targeting for efficiency is budget to budget down 23.9. The focus area for the largest area of expense savings is nearly 30 million in what we've put together for efficiencies within our care for our patients. We're looking at not reducing care. We're looking at how do we make it more efficient? How do we ensure that at the end of the day, when the patient receives the bill, that everything is appropriate? We have ensured that the care that we delivered was what was necessary, as well as what was in the best interest of the patient in terms of affordability. And are there any opportunities that we have there for reducing cost of care? So I don't know if that covered everything, but that is kind of the intent around our cost savings and focusing on the affordability component.
Yeah, okay, so that's about how I understood it. So that totals right around $90 million, give or take a little bit. My question is, when I look at the chart on page 4 with your fiscal year 25 budget, the total expenses at UVMMC are 2.254 million. And the fiscal year 26 budget is 2.347 million.
Yes.
And so that's about 90 million, around 90 million-ish more. So what are these savings coming out of if they're not coming out of the total expenses?
Well, you can see that they are primarily, when we look at budget to budget increases based upon inflationary rates, and also in our salaries area, all of those are subject to inflation and cost increases. So we're pulling those down in our non-salary. That has been our focus for non-salary expense reductions. So when we look at where we're projecting for FY25, you can see that our projection based upon the patient care that we've delivered is running, you can see that $1.055 billion, and we're reducing that to $1.009 billion, almost $1.010 billion. So it's that line that you're primarily seeing that reduction in.
Okay, total non-salary expenses went from $1.5 billion to $1.009 billion from 25 budget to 26 budget.
Correct, budget to budget.
Okay, so that's up. These are all up, is what I'm saying. And you're saying that there's expense reduction, but these are higher.
Yes, sir. You are budget to budget. You are exactly correct. The actuals that we are experiencing are exceeding our FY25 budget. Some of those we've actually walked through in our mid-year. Part of it is related to higher than anticipated expenses. Part of it is related to the additional care that was delivered. So we've tried in our bridges documents to break out anything that's generating revenue. And then we're looking at how can we, when we're looking at delivery of services, how can we make the delivery of services without significant reductions move from that $1.055 billion down to that just right over $1 billion.
I think the key missing piece, Chair Foster, is the growth in terms of volumes, any new drugs, those types of things that when we talk about expense savings, the way that I would look at it is the cost would be that much more, that would be that much higher. So, pick the $90 million figure. Had we not done that, because we do have increases due to volume and other related expense drivers that are all tied to doing more than we did in the prior year.
All right, so I mean, I'm coming at this from the perspective of the people paying the tab, and the people paying the tab are not saving $90 million over last year. They're paying $90 million more than last year. And what you're saying is, from your perspective, it should have been even more than 90 million. It should have been 180, but you reduced it by 90. So Vermonters are only experiencing 90 million more. Is that a fair summation?
What I would like to add to that is a perspective. How I look at it is what Mr. Vincent mentioned, it's related to care delivery. And what we're looking at is how do we deliver that care at a lower rate? So when we made our budget for FY25, we've gone into a mid-year and shown where our revenue has come in higher. But there are also, those expenses are also in that FY25 projection column. So they're both tied together. So it is correct that we are exhibiting additional revenue and the offsetting expenses, and we're working to reduce both of those because that's the affordability factor. And there is a budget, and then there's the reality of delivering the care. And so what our FY26 budget does is try to take into account what care needs to be delivered and how can we do it less expensively, because when we look at what we're actually experiencing, what our patients are actually demanding of us, that does exceed that 25 budget number that is in that chart on page 4. And that is exhibited by that middle column. So it's a matter of trying to take what the reality is and make it more affordable.
Do you have any sort of spreadsheet that walks us through what, I would think of subtracting it from the budget, and you're thinking of subtracting it from some other number. Do you have a spreadsheet that shows us that other number from which you're subtracting these savings?
Certainly, that is with our projection that we provided. And we can certainly add to that if there are other components that need to be explained. So we're required to submit our FY25 projection for revenue and expense and how that looks different from our budget. And we do attempt to provide explanations for that variance in terms of what our projection is looking like. And that is where you would see the increase in our volume, increase in the expenses related to care delivery. We've mentioned every single month in our reporting out to Green Mountain Care Board staff about the high cost of drugs, and that is certainly in our non-salary expense. So the reality of FY25 budget to FY25 projection, the difference in that is the reality of caring for the patients in FY25. So recognize it is an increased budget to budget, but I will say that we are working extremely hard to bring it very close to our FY25. And percentage-wise, I think that you would see nominal increase given the level of care that we are delivering. So I will say that we are committed to meeting the affordability. There will be a runway and a path that we have to get there versus, a cliff for us to fall off. But we are, and I think it shows in our numbers that we are committed to that. But I'm happy to provide anything additional. Didn't mean to cut you off there.
No. I appreciate that. Just seeing I want to see what the math is that you're projecting the subtraction from. That's what would be
absolutely
helpful. Okay.
Absolutely.
And I understand your point about a glide path and a cliff, and that's something we try to understand and evaluate while recognizing that Vermonters feel like they're being driven off a cliff if they haven't already, particularly with some potential other changes coming. I want to talk briefly about contract negotiations. Is Ms. Champney still on? She might be the right witness on these.
Yes, I'm here.
All right. So the first question I had was the liaison to UVM, the team submitted a recommendation to DFR and the Care Board last week that we should cap all prices at 500% of Medicare. And I was curious if UVM has a sense of the revenue impact that cap would have.
We don't, we saw the same letter when it was posted online and discussed with the liaison. We don't have an assessment yet, Chair Foster. We are in process of evaluating. As you know, it's complex of what percent of Medicare to not go down the rabbit hole. So it would be significant. We do have some that are under 500%. And then obviously, as you know, we have some that are higher and at times greatly higher. So we don't have that number yet, but I do know it would be significant.
Okay. Yeah, and the high margin services, that document was a little bit different than I think some other hospitals had submitted it. Can you, and maybe Member Holmes already asked this, but can you provide us a list of services that are above 500% of Medicare and the corresponding revenue from those services?
We can follow up. I might have some follow-up questions either for you or your staff to get to the right level.
Yeah.
So if that's okay, there might be a conversation just to make sure we're providing you with what you're looking for.
Yeah, of course. One of the other things that we've heard about is this negotiating dynamic that sounds difficult. And I think in the liaison's letter, they wrote that UVM has advised Blue Cross that if you don't give us this budget or this rate allocation, we won't see Blue Cross patients. Is that allegation accurate?
Those words have never come out of my mouth or my team's mouth, so I would not categorize that in that manner.
Has UVM in any sense ever threatened to not be part of Blue Cross's network?
Predating me on potential terms, I know we have gotten to very tough conversations before. To my knowledge, there's not been a termination conversation.
And no threat of a termination or a discussion of it?
Not that I'm aware of.
Would there be somebody else who would be aware of that, or would you be the right person if anything like that had ever actually happened?
It depends on how far back you would go. I've been in this role for 4 years, so I can tell you that. Before that, I would defer to Rick or others.
Mr. Vincent, do you have any knowledge of UVM or the network ever threatening to not have Blue Cross in its network if it didn't accede to UVM's contract demands?
Not that I can remember, Chair Foster, but again, that's tapping the memory bank a little bit. No.
Has UVM ever agreed to a lower rate increase than Blue Cross? I'm sorry, than the board, the Green Mountain Care Board approved with Blue Cross? Sorry, let me strike that as a terrible question. Every year the board issues a rate cap increase. Has UVM ever negotiated and agreed to a rate cap increase with Blue Cross below the board ordered cap?
So I'm going to give a high level. If we want further detail, I would ask for executive session just to the contract terms. And I think I've testified to this as of last year, as we submit our budget, it's based on revenue assumptions of utilization, payer mix, and collection rate of the rate we need. How we apply that rate at each payer is different because their starting point is different. So an MVP is different than Blue Cross on how they pay certain terms. We also take into consideration, how we're working with payers, whether it be on a value-based program or the administrative burden. So high level, we contract in, if there's a -1 for last year, for example, we apply that -1 across our payers. There are definitely nuances on how that gets applied and how we work with the payers to understand their areas of focus.
My understanding is historically the network and Blue Cross ensures, and again, Ms. Champ, you're correct. If we get too granular into contract negotiations, we can do executive session. I'll try and keep it high level. My understanding is the negotiation will yield rate increases on some services that are extremely high, well above the care board cap, and some will be below. Is that accurate?
I'm going to restate what I believe is accurate. So I would not say that's accurate, and I'll give last year as an example.
Do the years before, because I understand last year is a little bit different.
Years before, we would increase some that may be above if you approved a 3%, so I'm going to use an arbitrary number. If you approved a 3%, there may have been services, and there were services at Blue Cross or a Cigna or MVP that may have been higher because of either comparison to where we are with other payers, if they come, or excuse me, other providers that they come to us and ask for a lower rate. There may be a lower one. So in aggregate, we would get to that 3%. And yes, you're correct. Some might have had a 6% increase. And we do that modeling with each payer to make sure it comes in aggregate, also starting off with the same base point. So we know what we're modeling with our payers.
And I may have asked this last year, but do you model or audit during the year to make sure your modeling was accurate?
So we look at collection rate, I'll say at a high level, as I know the CFO partners do, of what we're expecting. And that takes into a couple of terms we're actually getting from payers, where they do put in payer policies that are not expected at budget. We are working, and we had this in conversation with Blue Cross, so I can say this at a high level. We're working with Blue Cross to get to that audit or reconciliation. Chair Foster is another term. Not all payers require or want that, and they'll check the modeling. With our unit costs, we feel very comfortable that we've agreed with our payers. There has not been a formal audit. If a payer comes with a concern, they have that right. They have at times. And if we identify an issue, we go to payers. So it's, as it should be, in my opinion, a collaborative process of bringing up issues as we find them. There hasn't been an aggregate reconciliation to this date.
Okay. And one of the other issues we're trying to understand is the concept of revenue neutral, where an insurer may say, hey, you billed us wrong for this or this. And my understanding is at times UVM would respond and say, that's fine, but if we're going to make a change, it needs to be revenue neutral, as in you need to make up for that removal of payment in some other area. Can you describe your awareness of that?
So at times it does happen as we create our budget. We don't know of payer policies. We are working with our payers to get out ahead, saying if you're going to change a policy, I would not categorize us as winning those budget neutral. So they will have a negative. For example, ED downcoding has been discussed, I believe, or at least you've heard it in the news. Many payers, not just Blue Cross, have implemented those policies, and we have not been successful. In the most part, we will go back with payers to say, this is why we have appropriate coding. You saw in the legislation, the cotivity edits by Blue Cross, and which led to Act 111 last session, 2 sessions ago. We did not win that. And, we worked through legislation to limit it. So it is a handful at times, I'll say, in a positive way, and a positive collaboration, specifically with Blue Cross. There was an HIV test that was being limited due to their payer policy. We raised the issue from our clinical team and our revenue team, and they actually added it to the policy to say it would be covered because it was an unintended consequence of an edit. So we do have those conversations, sometimes to ensure we're getting paid for the important test. Other times it creates a significant hole in our budget that was not captured.
When you say hole in your budget, the Care Board's budget approval is a cap. So if there's a hole in the budget due to appropriate utilization management, why would UVM recover that?
So I'll go back to how our budget is developed. We have our commercial rate based on what we feel we need to meet our budget expectations. If there's policies, for example, and changes on how implants are paid, which that came out a couple of years ago on a number of our payers, that is a very large impact, especially at the medical center. We're doing a lot of implants. So that is expected from budget, so from our budget terms. So I believe it goes to the different view of how we're making up our commercial rate is not expected as a cap. I sometimes think of that, it's the sticker of what we actually need to meet the revenue. It's not a negotiation standpoint of I'm going to start higher, you're going to start lower, and we come to the middle. It's what the rate is, and that's what we're filing with you.
And Ms. Chapman, this may be for you or maybe for others. Have there been any discussions at all regarding moving infusions from Vermont to New York to avoid the cap? And I know we asked Dr. Leffler this, but since others are on, I wanted to ask it again.
I think Dr. Leffler answered it correctly, Sunny.
Yeah, I'm just going to say the same thing. Our goal is to keep care close to where the patients are. And so that hasn't changed. And if there's an opportunity that we identified a year ago, 2 years ago, where we're seeing a large number of a particular kind of patient, GYN onc patient coming from New York, we say, can we provide that service? Is there enough volume that we ought to provide that service closer? And it could be CVPH or it could be Middlebury at Porter. So that hasn't changed. And so I don't think there's anything else that is there. Typically, what we've seen is patients come to Vermont because come to Burlington because that's where the services have been. And I think that will probably continue, but our goal remains the same. How do we deliver care close to where the patients live?
Yeah, I think providing the care in the place closest to the patient that makes the most sense is entirely logical. Moving patients to avoid a cap would be something different entirely. But thank you for that answer, and I appreciate you guys responding to that. I wanted to move a little bit to days cash on hand, and these are probably for Mr. Vincent. What is the floor for days cash on hand for the network to not violate the bond covenants?
So up until a month ago, it was 90 days cash on hand. We've since updated our MTI just to give us a little bit more cushion, knowing all the potential unknowns that we have with, as we shared in our opening remarks, and I think the board is aware of as well, potential cuts coming to Medicaid, premium tax credits, all the unknowns that we have. As we look into the future, we did get 50% of our debt holders to approve a new master trust indenture, which brings that now down to 75 days.
And currently, the health network days cash on hand is 131.
Correct.
And what is UVMMC's days cash on hand currently?
I think that was on a slide that Judy had. Judy, I don't know if you can take a look at.
Yes, we were projecting based upon the budget that we submitted for our days cash on hand to move to approximately 134 days. However, I will reiterate that was prior to the final rule for Medicare, which does bring down our days, at least by a day, 1.25 days based upon the change in the final rule.
Okay, and that's for 26 budget.
Correct.
Okay.
And we're running about 130. We run anywhere from 128 to 131, 132, depending upon activities in the market, how non-cash things are flowing through. So that's about where we've been running.
Got it. Okay. And then in the appendix that was submitted, page 40 in the submission, it's the balance sheet. And it displays the UVMMC, CVMC, and Porter balance sheets, but it does not provide a balance sheet for UVM Health Network. Are there additional assets such as cash? I ask it each way. Is there additional cash and cash equivalents at the health network beyond what's displayed on page 40 of the appendix?
There are, and we did have some correspondence with your staff on the fact that we don't generate a health network balance sheet. We have a health network financial framework, which sets the targets for days cash on hand, debt, margin, all of our key metrics. But to answer your question, yes, we do have other assets besides what you see there on that balance sheet for those three organizations.
Okay, and what you're showing us in this balance sheet you provided, that's current as of when?
I'll have to defer to Judy or maybe to Mark on exactly what time period that actually, if one of your staff has that, perhaps they can pull it up. The time period might actually be listed on that schedule.
I didn't see it myself. All right, I think I get the sense. So your audited financials from September 30th, 2024 have UVM Medical Center at 234 cash. This has it at 238. So, and the other numbers are relatively aligned as well, give or take 10 million here and there. And the cash at the health network as of September 30th, 2024 was $68 million. The short-term investments was $107 million and board designated assets was 115. I'd just ask that you provide an updated set of numbers consistent with what you provided in page 40 of the appendix. And in terms of the assets at the health network, cash, short-term investments, and board designated assets, where did those come from?
So a big piece of it came from some debt that we incurred. I'll have to go back and see exactly. We borrowed about $50 million, 4 or 5 years ago. Might actually go back further than that to capitalize the health network. In addition, we've been generating obviously some investment income and some other revenues, but the bulk of that asset base goes back. We can get you the exact date on when we borrowed money to capitalize the health network.
Okay. It's close to $300 million. Was there any cash provided from any of the hospitals up to the network?
So there is, as we're paying for shared services, there are transfers that are happening between the hospitals and the network as well that we can break that down in terms of how that's accumulated over time.
Okay, and which entity incurred the debt that you referenced?
So that was incurred by the health network.
Right. Yeah, if you could give us a breakdown of all the contributions by the various hospitals, including New York, that went into the unrestricted assets at the health network, that would be helpful. And how do you allocate those network assets to member hospitals?
So it depends on which asset you're talking about. So investments, for example, are all managed centrally at the network level. They're in one account for investment purposes, but we do keep track of how much each partner's balance of that overall investment portfolio. In terms of cash, we have each partner still has a cash balance, has cash accounts. Most partners have short-term investment accounts as well. So we're managing all cash and investments centrally, but we're still keeping track of exactly where it came from, who holds what. As I said, many networks at this point don't have that level of breakdown anymore. The cash is all consolidated into one account, and all the bills are paid from one account. But we haven't made that change yet.
Are you contemplating making that change?
So it's something that we're considering, but given because there's a significant amount of efficiency that can be gained by making this change, but we wouldn't make that without discussion with the board, because obviously the accounting and just where those assets sit, we want to make sure that it was very clear what we were doing before we made any of those changes.
Okay. If you could give us a breakdown as well of the balances for each of the hospitals relative to those assets, cash, short-term investments, and board designated assets, that would be helpful as well. In terms of those network assets, how are those reflected in your calculations of member hospital days cash on hand?
So the only things that can count in days cash on hand are cash, short-term investments, and then unrestricted long-term investments. So any restricted funds that have been donated to the hospital, the network, don't count towards days cash on hand. So it's cash, short-term investments, long-term, unrestricted long-term investments divided by the average daily expense to run that particular hospital. And then we have an overall number for the health network, which is 9.4 million. So when you combine cash, short-term, and unrestricted board designated funds and divide that by 9.4 million, that's how you get to the 131 days cash on hand that we're showing in our financial statements.
Right. And when you do that calculation for days cash on hand for the medical center, you include both the medical center's unrestricted assets and its portion of the health network unrestricted assets?
It includes, yeah, anything that's attributed to the health network and UVM Medical Center. Yes, that's correct.
Right. Okay. So I'm going to make up a couple numbers because I don't have them, but the cash and cash equivalents at UVM Medical Center is $234 million as of 24. The health network has another $68 million cash. Let's say that medical center has, 50% is attributed of the network asset cash to the medical center. So you take the 234 plus 34, and all of that would go into that calculation for the medical center's days cash on hand.
No, so the medical center's calculation would just be based on the medical center's accounts, not the health network numbers that you were quoting there.
Okay. But you said the medical center actually has accounts for cash, short-term investments. The medical center's portion of those network assets is not included in the medical center's days cash on hand methodology?
It is for investments, and we can get you a crosswalk because some investments actually are held at the network level as well. So we can give you a breakdown of the portion of the unrestricted board designated funds that are part of the UVM Medical Center's days cash on hand.
Okay. So looking at the balance sheet from 2024, 68 million cash, 107 short-term, 115 million board designated at the network. What you're saying is some portion of that amount of money is being included in the calculation of UVM's Medical Center's days cash on hand.
Correct.
Okay. And you'll give us a breakdown of how much of those assets are being included?
Yes.
Then the New York hospitals, we had some confidential data relating to prior years' financial performance, operating margin, days cash on hand. And I think you suggested earlier that they're closer to break even and Alice Hyde is positive. What is the days cash on hand for the New York hospitals currently?
Yeah, we can get that to you, Chair Foster. We'll give you for each hospital, and if you want a combined number, we can provide that as well.
Okay. Yes, please. I did some very rough back of the napkin calculations on the day's operating expenses for the New York hospitals based on the 2023 Form 990s. So it's a little bit dated. But it was about $453 million was the expense for CVPH, 105 for Alice Hyde, 60 million for Elizabethtown. And so if I want to come up with the days cash on hand calculation that's needed, to hit 130 days cash on hand or 175 days cash on hand, I would divide that total amount of money by the number of days in a year. Is that correct?
Yes.
Okay. And then, all right. So my rough calculation came to $1.7 million. And then to calculate what 130 days would be, which is about the networks, it would be $221 million those New York hospitals would need to contribute to equally contribute to the network-wide days cash on hand. Does that sound roughly correct?
Yeah, I'm not quite following the math, but I think when we show you we can give you the exact number of the cash for each partner, the cash in the short term and the investments that are sitting at each partner and the network, and give you the average daily expense for each partner so you can see exactly how we get to 131 days cash on hand.
Okay. And that'd be great. And just directionally speaking, are the New York hospitals contributing at least 130 days cash on hand for their portion of the network-wide days cash on hand?
Again, I'll have to take a look. I know that Elizabethtown has, I think, close to over 200 days cash on hand. The other two partners have less. So when the fact that you're looking at it as three combined organizations, I'd rather just do the exact math just to get you the number that you're looking for.
Okay. I'm not suggesting anything with this question. It's merely a question. But if the network were to drop the New York hospitals, would your days cash on hand needs decrease?
So we anticipated this question, and it's a very theoretical question because the impact that the New York hospitals have on our overall network is incredibly positive from a patient flow perspective, even a financial perspective, as Dr. Leffler was describing earlier. Being able to keep those patients local impacts the amount of access and capacity that we can have at the UVM Medical Center. So it's a little bit of a theoretical question. I'll just leave it at that for right now.
Understood. It's a theoretical question. Let me probe that. Essentially, the testimony earlier was that, hey, this is positive for Vermont because of the financial impact that we'd have if all these patients were here rather than over there. And also, it's better clinically to be able to have them here and there. But doesn't that answer suggest that those hospitals wouldn't exist but for Vermont's financial support?
Again, a bit of a theoretical question there. I will just say, just specific to the UVM Medical Center, we in the numbers that were quoted in my opening remarks, just so that the board and the staff know where those numbers came from. It comes from the New York and Vermont funds flow document that we've been providing for many years. I think we started providing it in 2017, and the data goes back to 2015. One of the numbers on there is actually the margin that's generated by the UVM Medical Center through patients coming from New York. When you take a look at just that number and compare that to the funds flows, if you will, trying to take a theoretical question and bringing it down to somewhat of a analytical question or analytical answer, if you will. When you take a look at the margin that's been generated at the UVM Medical Center by those patients, which those patients certainly, if they were not part of the UVM Health Network, those patients could be going to Rochester, they could be going to Albany. It's not a guarantee that those patients would be coming here to the University of Vermont Medical Center. But when you look at that margin that's generated compared to the investments that have been made over that same time period, the days cash on hand impact is fairly minimal. So when you look at the margin compared to the investments, think the calculation I did was about a 4-day cash on hand difference. If that margin were no longer, the margin was gone, and if the investments that were made in the New York partners were eliminated.
Has your flow of patients from those New York hospitals increased with your contributions to the New York hospitals' finances?
I think even on that document, Chair Foster, it looks like it's been pretty much steady. There hasn't been an increase, and if anything, as Sunny and others have stated, we're trying to actually keep more New York patients local. Better for them, better for the communities. I don't know, Steve, if you have any more anecdotal information, but just looking at that report, I think you see a pretty flat number coming from New York.
Yeah,
right. Sorry, Dr. Leffler. I actually just want to stay on this line of questions for a second. If it's flat, I guess I don't understand why. So UVM is contributing some financial support, funds flow, I think as you called it, to the New York hospitals. It's tens of millions of dollars. And you're saying, well, we get margin back. But if we don't have any increased margin per your calculations as we contribute more funds flow to New York, what's the benefit?
Again, this gets into a little bit of a theoretical question where those patients could not be, there's a case to be made that those patients would not be coming to the UVM Medical Center if it were not for this system being in place. I think that's the point that I'm making there. That margin would not exist, would not necessarily exist if this system did not include those New York partners.
What analysis have you done of how many patients wouldn't be coming to UVM if that financial support hadn't been provided?
Again, theoretical question, but we know from early on in the development of our network that we had a very close relationship with Canton Potsdam. The referral base coming from that region was very well established. They actually decided to affiliate with Rochester Regional Memorial, which significantly changed our referral to UVM Medical Center from that area. Since the network's been formed, Glens Falls Hospital, which is on the edge of our market area, has affiliated with Albany Medical Center. And so, again, it's a theoretical question on would CVPH and Alice Hyde have affiliated with Albany Med instead of the UVM Health Network if that relationship didn't exist. And if it did, then that margin would go away.
It sounds like a theoretical answer. You're suggesting that hypothetically, if you hadn't provided financial support to the New York hospitals, these patients would go elsewhere, but that's hypothetical, right?
Can I add to it, but I don't want to interrupt you if you want to keep going, Chair Foster.
Yeah, maybe Mr. Vince, if you can answer that, and then we'll turn to you, Dr. Leffler.
Yeah, my point is it's not a guarantee that those patients will be coming to the UVM Medical Center. Is I think what I'll just end on.
It's not a guarantee that they wouldn't either.
I think there's a couple. Yeah, I think there's a couple possibilities, and I agree. All of this is hypothetical, theoretical, whatever. One possibility is that those hospitals would affiliate with Rochester or Albany, and that would potentially have a huge impact on our specialty services. Cancer care, heart surgery, thoracic surgery, high-end neurosurgery, NICU could all be affected by that loss of those patients coming here. That would be devastating to our academic mission. The other option is that they would not be looked at as a good site for affiliation and they'd be totally on their own. In that scenario, they probably lose even more services without support, and we're overwhelmed with patients who don't need tertiary care but are coming to Burlington for access to care. Either one of those options, for totally different reasons, is a giant problem for the academic medical center. Either too many patients that we can't serve because we don't have beds for them, or not enough specialty care. Having those be part of the network, stabilizing the appropriate referrals here, keeps our specialty services strong for Vermonters and keeps the right patients in New York. So we're in this balance. I haven't seen the exact dollars to show that is the right balance, but academic medical centers across the country do it for exactly this reason. So that's what I wanted to add, and I appreciate the opportunity to do that.
Thank you. So when the medical center has financial concerns here, you come to the board and you ask for more commercial revenue, and we may or may not give it to you depending on the year. Why don't you do that with the New York hospitals? Why not be financially solvent and sufficient with New York payments?
So I'll just say that the commercial rate increases that we've presented to the board, hopefully we've had a really transparent track record where it's not been based on financial difficulty. It's been based on the cost inflation that we're expecting for the coming year, taking out the government payment rates that we're expecting, and that's been the calculation that we've been doing for commercial rates for as long as I've been in this role. And even if you look at the presentation from today, the breakdown of the commercial rate and what was required wasn't based on the need for achieving, because of financial difficulty or
well, the cost inflation can lead to financial difficulty. I mean, I'm just generally, you ask for more money because you say you need it. And so my question is, your New York hospitals need more money. Why don't you get it from New York?
So in terms of commercial rates and the negotiations in New York, actually, those have been increasing, and Kaylee Chankney can provide. I may be getting into some area.
But here's my point: they can't be sufficient because the days cash on hand at your biggest hospital is exceedingly low, and at your second biggest hospital is exceedingly low. And there's a funds flow of tens of millions of dollars from our Vermont Academic Medical Center to the New York hospitals. So what you're getting in New York is not sufficient. Is that fair?
Yes, it is fair.
Okay, so why are you not getting enough money for those hospitals from New York?
So that's where I was going with my point. So when we're looking at the commercial, and again, I don't know if this is executive session or not, but the commercial negotiations in New York have looked very, very different than they have in Vermont the last few years. The increases that we're seeking are much larger. They're going to be much larger again this year. We do the same thing in terms of advocating at the state for additional funding. So the same things that we're doing in Vermont, we're doing in New York.
Okay, and the $103.5 million in the due from to UVM Medical Center. Can you give us a breakdown and follow up on what who all owes that money? I think I can roughly figure it out, but that'd be appreciated. And then I believe last year you testified there's no interest accruing on any of that money for the UVM Medical Center.
Correct. Those are not considered loans. We're a consolidated entry. We're an obligated group, so there's no interest that we're one organization.
I'd rather see it go the other way, where your New York hospitals are lending Vermont money with no interest. I know it's all, or funds flowing, whatever you want to call it. It just doesn't seem right that you're lending money from this hospital's reserves to another hospital, not lending, whatever you want to call it, financially supporting them, funds flowing. It just doesn't seem right to me to not have any interest on that, because that money, am I correct, that came out of UVMMC reserves?
Again, we'll have to get you the breakdown of exactly where that came from.
Okay, I'll finish up here. Your budget for fiscal year 26 has a $72 million margin for UVMMC. And my question is, sorry, 72 for UVM and 82 million for the Vermont for the Vermont Health Network hospitals. And this money, to the way I look at it, could be used to support UVM and contribute to the balance sheet and financial stability for UVM, which is very important. It could be not approved It could help lower Vermonters' healthcare costs. It could be not approved and support FQHCs that are struggling to stay open. It could be not approved and increase Blue Cross Blue Shield reserves and protect solvency. It could be not approved and it could support other community providers. Why should I vote to provide this money to UVM as opposed to any of those other competing interests?
So are you suggesting that you would just take the money from UVM health system and then distribute it to all the other places?
Well, there's a number of mechanisms that would have to happen for that to occur, but we could not approve it for UVM and then the insurers wouldn't pay it out. And then it could go to their solvency. It could go and flow through to their members who are struggling with healthcare affordability. It could go to lower rates that then are used by the insurance companies to support FQHCs or community providers. Yet the money you're asking for in that amount is money that is not available elsewhere. My question is, why should I vote to approve it for UVM and not those competing interests?
So the reason that we ask for a margin is because it goes in to support the expenses that we have both on the deferred maintenance and capital for our system, right? So we've already been putting off those deferred maintenance projects. And so not having that money just means it kicks that can down the road even further.
No, I appreciate that. Let me just interrupt. That's the exact same situation for so many others.
Absolutely.
So
Absolutely.
I totally appreciate that and respect it. But my question is, why should I approve it for UVM instead of those competing interests?
Because we provide an incredible service to the entire region here. And so continuing to diminish that ability for us to do that means that the services will not be able to be provided at that same level. That's the challenge. On the New York side, I think I'm just going to summarize what I heard from everyone to make sure that we're on the same page. You might not agree, but if we were not part of that network, if we stopped being a part of the network, as you suggested hypothetically, I think what would happen is that those patients that we currently refer here would go to all those other places because those places are competing for those same patients right now today. Cardiac surgery, neurosurgery, orthopedic surgery. On some of them, we get those patients and we get them to come here and we see the margin value and the provider tax value for that. We also see the value that it provides for us to be able to simply provide those services, whether that's pediatric subspecialty care, NICU care, cardiac surgery, neurosurgery, cardiac catheterization. The only one in Vermont that does those today. On top of that, if we weren't part of that network, what we would see, because patients don't follow borders, and if we weren't supporting the New York hospitals in the way that we are, the other patients would also come to Vermont. They would come to Burlington largely. Those are patients that now that we are working hard to provide the care there. If we stop doing that with the support, all those patients would come. Those are largely New York Medicaid patients that we would have to provide service legally. The borders are irrelevant in the provision of services. We would lose money on those patients. The margin would be negative, and they would crowd out other patients that really need to come into UVMMC. That's the challenge, and that's the rationale for why we try to manage those. The next part, I just want to make sure that you see it, that from FY23 to today, we've made enormous advances for those hospitals to maintain their operating margin. That is to break even or be slightly positive. That's the work that we've invested over the last few years to be able to do that, which only makes Vermont stronger in our hospitals. All of that work is to tie into affordability here in Vermont. The work that we're doing across the system is focused on how do we make care more affordable right here for every one of our hospitals. And so we started with that quality of care and affordability. All of this work ties to that right here in Burlington, as well as all of Vermont. So that's the reason you want to continue to sustain that. If that breaks down, it would be devastating to Vermont. It would be devastating to the region and to Vermont.
Chair
Okay,
Foster,
thank you.
If I can add to Dr. Eben's answer, you asked a great question, and I totally respect the challenge the Green Mountain Care Board faces with deciding where dollars are going to go in Vermont to keep care as affordable as possible. And you outlined a bunch of places that all truly need the money. What I want to say is, I'll speak for the UVM Medical Center because that's the budget I was most involved in. The budget that we built this year met the guidelines the Green Mountain Care Board sent out and did the hard work to make sure that within those guidelines, we could have a margin, because we need a margin to be able to support our people, fair and competitive wages for recruiting and retention. It has a margin so that we can keep our equipment current, new defibrillators, new equipment at the hospital, most current updated equipment to take good care of the patients that we serve, and to build something like the outpatient surgery center that allows us to provide care cheaper and more efficiently and affordably going forward. The margin that we submitted, I understand it's a big number. I understand the size of the impact when your budget's $2 billion, but that is the margin. So the margin that we submitted is the margin we believe we need. If the Green Mountain Care Board, in your regulatory power, realigns those dollars to somewhere else, we'll figure out what we can do with the budget that you give us. But that was the budget that met guidance and was what we believe we need to move forward on many big projects. So I appreciate the really difficult decisions that the Green Mountain Care Board has to make dealing with affordability for Vermonters and the other regulated entities that you have regulatory authority over. And thank you for giving me the opportunity to answer.
Thank you. And thank you for your responses and for your budget. I know you all worked very, very hard on this, and this is part of the process is we need to make these hard decisions. And oh, sorry, Ms. Peakley. I want to move on to somebody else because I've taken a lot of the time.
Certainly. Thank you. I did just want to add that something I said early on is when you're talking about numbers that are billion or million, it really sounds like surely you can just shave off some. I do want to say that there are a couple of things that I worry about in FY26 without an appropriate margin, and that margin is coming in at 3%. So not a 10% margin. It's really right around 3%. It is a big number, 72 million. I also wanted to say that a couple of things with that margin, if reduced, doesn't necessarily mean that patients won't continue to come and that Blue Cross or other insurers or Medicare won't continue to incur costs for care delivered. So we're not looking to restrict care as a result. I also want to mention that not all of that margin comes from our commercial. Remember, we do have other revenue in there that is quite significant that would be diverted if we're talking about giving that money elsewhere. And we need to make sure that revenues that we're generating, we also are able to cover the expenses that are related to that when it's not directly coming through one of our commercial payers. So I just wanted to make sure that you understood that we wouldn't be necessarily able to close off inflow of patients because we are here to treat them, and that we do have, I would say, one of the most complex budgets in terms of the different types of revenue that come in to make up that margin, and do appreciate the complexity that the board has and looking at the affordability, and we want to partner with you on that and understand it is a very difficult decision.
Understood. One last one. The 103 million due from, is that reflected in UVMMC's days cash on hand?
I don't believe so, Chair Foster, but we'll validate that calculation.
Okay. All right. Thank you all very, very much. I'll turn to Member Holmes.
Hi. I know it's getting late, so I just have two areas of inquiry, but I think they'll be short. One that hasn't come up at all, but the UVM Health Network is the sole parent of One Care Vermont. That doesn't come up at all, but the reason I ask is that I'm curious what the value of the reserves are at the end of this year, and what is the planned distribution of those as One Care Vermont sunsets.
So we can follow up with specifics there, Member Holmes. I don't want to quote. I have a number in my head. I think it's somewhere in less than $10 million. I think at the end of the day, after all bills will have been paid. So we can get you a projection from OneCare on exactly where they think that will land. And the run out is actually continuing all the way through June of next year. So even though the program's closed down this December, there's still some cost, granted much less cost that will be incurred from January through June of next year to run down the programs.
And I think also just it would be helpful to understand the distribution of those reserves to the member hospitals, or what's going to happen to those reserves would be helpful to understand. There's also are the FTEs associated with OneCare Vermont currently in the FTE count that we've been seeing at the health network? Or is it separate?
I'm not positive about that. I think they may be. And so we'll get back to you on that as well.
Okay, and then it would also be helpful to understand, will they be retained, or what's happening to that FTE count when that organization sunsets? Okay, and my last question really is, it relates to quality, and I thank you for the transparency and sharing some of the star ratings. It's a concern of mine. And, as we look from fiscal year 22 to fiscal year 26, we're seeing this centralization, we're seeing this consolidation of shared services related to improving quality and improving population health. You have a department, value-based care department, you have a quality department, you have a PHSO, you have the ACO as well in there. I'm not sure whether they're all fully embedded in the PHSO or not, but as we look from 22 to 26, it increased in the expenses associated with those collective departments. Aside, I'm ignoring the ACO now. $21 million in 22, $41 million budgeted for 26. Staffing went from 139 to 237. So that's a lot of resources devoted to improving quality and population health outcomes. And I looked at, the star ratings. You mentioned where the Vermont hospitals are, but Alice Hyde is 1 star, CVPH is 2 stars, CVMC we know is 2 stars, Porter and UVMC are 3 stars. So we no longer have any 4 or 5 star hospitals in the network. That means and half of your hospitals are in the bottom third of all hospitals in the country, and none are in the top third. So, and when I look back to 2022, UVM was a 5 back then, CVMC was a 5 back then. So I just want to articulate that I'm concerned that sometimes centralization and consolidation of those types of services may move people away from where, at the point of service where quality can really be improved. And I want to ask you, how are you assessing whether or not this is an optimal approach, this centralization, this consolidation of all this quality? And how are you assessing that the growth in staffing and expenses related to quality are providing a positive ROI?
Maybe I'll start. I'll say that the consolidation of the quality services really hadn't started till probably last year. And so the network-wide quality as a network shared service really hasn't happened yet. It's really, the process has just started over the last fiscal year. That's number one. I think you're right. I think one of the concerns that you raise is actually what our hospital presidents have raised, is that as we've squeezed on our expenses across our system, we probably squeezed too hard in that quality space, because quality is a little bit removed. You think about the people that are doing that work are not direct clinical facing. They're the people in the back. You're absolutely right. And so I think we've, really led by Steve and Ramsey here, have really pushed back on the commitment that we need to make both in the FTEs and the people that have to be in that quality space. So we've done that, and we've really reorganized and realigned that space to drive the work there, hired very specific people in order to do that. So I think you're right in everything that you said there, but that we haven't really dedicated the resources and the people to do that. The contrary, I think we've squeezed from the outside and said, you've got to reduce people, and that hasn't worked well. The other part of that is, of course, all the things that you've already heard, is that I think we expanded dramatically during the COVID time period. We had lots of travelers in there, and quality did decrease in that space. And then we came back, we had to get back and right size that just back to the basics. But we've got a plan. It's driven by those CMS 5-star ratings of what do we need to do to target. We're utilizing the power of being able to centralize the data analytics and management to drive that back locally to say, here's what you need to do in your hospital, in your health service area specifically. So we're trying to leverage the sort of benefit and economies of scale that Drew just had. I think we strayed away from that, and I hear you, and we acknowledge and recognize that. I think all of our presidents have sort of started with that to say we know we've got to do work there. But you're right, it comes down to doing local work, but there's also value in the way that we can do the scale centrally to be able to drive that. So that's what we're trying to do. Invite Ramsey and Steve if there's anything else that you want to put into that space.
Yeah, so I agree with you. You have to have enough people on the ground. So we got the medical center to 5 stars before. I hate that we're not 5 stars right now. It really bothers me. We made a bunch of decisions through the pandemic that took our eye off it. And what I do know about being 5 stars is to be a 5-star institution, you have to think about it every day at every encounter. Every person here has to be focused on doing it right, doing it well every time. And in the pandemic, we lost that focus because we were focused on other things. As we started to do the work to build back, it does feel at times like the local hospitals don't have exactly enough people on the ground. And now we've started the hard work of making sure to advocate for what we need. I do think there's ways to use the power of the network to make sure we're all working on the same things, that we can have good best practices shared everywhere. But we have to have enough people at the medical center, and enough people at CVMC, and enough people at Porter to actually do the hard work. I just read a thing this morning before we started this that one of our floors decreased falls multiple by doing 1,000 leadership sweeps over the past 6 months. 1,000 times, hour by hour, the leaders are walking around to make sure that things are happening. That's how you get 5 stars. At the medical center, we do have a measure from Vizient academic data showing that we've started that climb, but that's just a small down payment to getting back to 5 stars. We have to sustain that and make it better. I am confident that the network has heard what we're asking for and that we will do better, but we're not where we need to be.
Okay, I appreciate that. I appreciate the efforts, and I hope when we're chatting next year, it's a different set of data that we're able to look at. Let me
add one last thing. We already know that all of the data for 26 for stars is already in. So really the work we're doing now will start to show in 27. That's the really hard part about CMS star ratings. It's got such a huge lag.
I recognize that. My last question is just about removing waste across the network. And I think we've talked a little about this when we were talking about the May Day meetings and things like that, reducing waste and duplication of tests and diagnostics when patients are transferred up to UVM. What do you accept MRIs from and other types of diagnostic imaging that's been done at another hospital, or do you repeat the tests? What are we doing about that?
I would say it depends, quite frankly. If we can, we try to use it. As you know, oftentimes when those patients come in, if they come in from an outside facility, we have to make sure that we actually have it. It's not enough to see the reading. We want to see the image. And then the question is the image good enough? So an MRI is not an MRI. A head CT is not a head CT. The protocols that get driven at different institutions are different. They're for us, they're all read by specialty readers. It makes a difference. So if you're a neurosurgeon and you want to do neurosurgery and you're getting an outside head CT, it may or may not be good enough for them to do it. We try to utilize what we have, but then it's not always the same though. That's the problem that we have. Certainly within the system now, both for labs and for radiology, we are totally centralized. So whether you get a blood test or a lab at Porter or at CVPH or at UVMMC, it's the same standard, same testing equipment, same protocol. So we can utilize that. Sometimes when they come from outside the system, we struggle for those reasons.
Is there any opportunity to improve that from outside the system? Sounds like you've made some internal improvements. Is there opportunities to work with other hospitals to reduce that duplicate imaging and reduce that cost?
Ramsey, do you want to talk about radiology a little bit?
Yeah, I guess, let me go back, Member Holmes, to the first question, because the repeating CTs and MRIs is like, that's right where it hits me in my clinical work all the time. And I will say that the need for repeating images or getting a secondary read has not been uniform, and we've kind of adopted to what's happening out there clinically. So to get some specific examples, right? So if I have a patient that has a multi-trauma that's seen in an outside hospital, and they transfer that patient in, and the images for us are really clear, and we can interpret those images, and we agree with the radiologist that's read those images the outside, we don't repeat those images at all. Sometimes we repeat just some of them. For example, if a patient gets sent to us and they have a CT scanner that doesn't have the definition that I need to look at the cervical spine specifically, we may repeat just the cervical spine CT and not the rest of it. But the most common scenario is that our radiologists, or as Sunny said, there's subspecial radiologists, but just in general, it's not always just the image, it's the interpretation. And so if I have an outside interpretation of an image, we oftentimes don't repeat the image, but we may ask our radiologist to do what we call a secondary read. So we have our radiologists look at the images that are coming to us from the outside, because if it's going to change management, we really need to get the most confidence we can in the read itself.
Okay, thank you. I appreciate that. We're short on time, so I'm going to pass it back to you, Chair Foster.
Thank you. Member Walsh, and we have enough time. I mean, we should finish this up. It's important stuff. So I appreciate UVM allowing us to take a little extra time tonight. Go ahead, Member Walsh.
Thank you. Yeah, and I can be quick. There've been a lot of great questions. So just a couple. We got several key exhibits from the network Friday and even late into the evening. And I was trying to look at those compared to earlier exhibits from the network and compared to years prior. Same data, same output, but it looks different. They're formatted different. So I started to wonder, are the tables that you send to us exported directly from your internal systems, or are they reformatted to be sent to us?
I think it depends, Member Walsh. So that some of those charts that you see there are the specific charts that your staff have asked us to fill out. So they provide the format. Some may be things that we've generated for the purpose of the narrative or the presentation. So it would depend on which one specifically you're taking a look at, whether or not it was the staff or it was us that generated that chart.
If our staff were to ask, would you be able to submit to us the same data format that you use internally, please?
Yes, we can submit data in any format that you would like to see it in.
Great. The networks in the past underestimated utilization. We were talking about this earlier with the medical center, and that's led to NPR overages and mid-year adjustment requests. Have there been any changes you've made to your modeling to prevent those large variances?
You want to start,
Member
Judy? I'm happy.
Yeah,
Go ahead.
certainly. Member Walsh, is there additional information you're seeking beyond what I provided? Are you looking, I was able to speak for my entity. Are you looking for that same information on other Vermont entities within the system? Or is there additional things you'd like for me to elaborate on?
I was just wondering if at the network level, there'd been any efforts made to reduce the variance from budgeted to actuals. The variances, as Matt jumped in after, the variances, particularly at the network level, have been substantial.
Yeah, I can
And-
speak to that. Yeah, again, on a percentage basis, as Judy, I think, pointed out for the UVM Medical Center, they've been within 5% the last several years, but it's a big, I hear you, Member Walsh, it's a big number because the net patient revenue number for the medical center is so large. We have, I would say, significantly improved the collaboration with our clinical team. So part of building our revenue budget actually is built from the ground up. So we connect with our radiology department, our lab department, the medical group, the peri-op team, the nursing leaders, and they all supply the first pass of the data that is the first building block of our overall revenue. And I would say we've improved significantly there in terms of looking ahead, trying to predict where certain trends are headed. That collaboration has certainly improved over the time that I've been here. The last piece that I think, with global budgets and with some of the other revenue caps and those types of things that we need to look at as a network is actually having some actuarial support. That's something that we haven't done. I think that's the next kind of frontier, if you will, in the building of our budgets, is to look at a little bit more in depth in terms of what's happening with populations, age, demographics, that sort of thing that still is not part of our budget building process.
So the collaboration with the members have improved and you're feeling more confident about the projections, but there hasn't been any external consulting or any modeling, new modeling, it sounds like.
Nothing external, no.
How confident would you say you are in this year's projections?
I think the challenge,
Go ahead,
Member Walsh.
Dr. Eben. Apologies.
Yeah.
Thank you.
yeah, I think the challenge, Member Walsh, is that I think when I've looked back, I think the challenge has been the demand for our services, for people choosing to come to our hospitals has exceeded what we've expected. And that's a very difficult, when I talk to the clinicians, when I talk to the emergency, it's a very difficult thing to deal with in the moment. And so you project what you think is reasonable based on past years, post-COVID, and then the demand is exceeded. And I think what we've largely done, from what I see, is that when those happen, we go above and beyond in order to satisfy that demand. And we haven't looked back towards where the patients are coming from to say, gosh, you should really stay at Gifford, or you should really stay at, you name the place. We've just opened that up. And if that's meant, opening up our services later in the day, hiring people to work on the weekends, we've done it. And quite frankly, without regard to whether that was going to generate a margin or not, without regard to what the revenue implications were, because I think the feeling was, I guess in retrospect, incorrectly, that that's what we should do, is just open it up. And I think as we've come together, what we've heard, as you've heard from Rick, to be more explicit, is that we need to really be very deliberate about how we do that and look for the alternatives than just opening up that service and doing more, particularly because we know the services that should be done elsewhere, if we do them, it is more expensive, and we acknowledge that. And so I think we've got to be smarter about that. And I've been saying this, but I talk to every single one of the presidents, and I know Steve does, across our entire state. And we are on, everyone's speed dial. We've got it. They call, we say, what can we do to help? What can we do to keep that patient there if we can help? And so I think that's been a shift that I hope we'll be able to see the results of in this coming year so that our estimates will be accurate. I think there remain a lot of unknowns, which I worry about. And the unknowns, of course, are what's going to happen with our Medicaid patient population, what's going to happen as a result of whether or not folks who are on the fringes of being able to buy in buy their insurance on the exchange? Are they going to do that or not? And how that's going to extrapolate out? I think there's a lot of unknowns there, but I think, I don't know if that helps or not, but I think we're a little bit more together on that today than we were in the past, meaning that any given hospital today can't just open up that door, open up that Saturday service, open up without us coming together and really talking that through and thinking about, is that the right thing to do for the community, for the state, for that patient overall in the long run? So I think that is different. I've seen that difference even now in my third year than compared to when we started. So I think we're going to see the results of that. Can I say it? I can't say it's going to be great. That's all we can do is try. Go ahead, Steve. I'm sorry.
Sorry to interrupt you, Dr. Eben. So what I would add is I've been coming to these hearings since 2011. And for most all the years I've come to the hearings, in general, the net patient revenue, if you could explain that your revenue was increasing because of increased utilization with new unique patients, that was usually allowed every year until last year. And then last year, the Green Mountain Care Board said to the network and the medical center, look, we're going to do this a little different now. We're going to hold you to that exact number. And so we've started to do that work of understanding that's a hard number now, and you really can't exceed it. And we have started to shift. We are dealing with our enforcement from 23. We have an enforcement that's in our 26 budget and will be in our 27 budget. We're working hard now to keep patients closer to home in New York when it's appropriate, in the hospitals across Vermont, and much more thoughtful about how the revenue comes in. But it was a change last year in our budget guidance, and we are working as quickly as we can to make sure that we keep the revenue down. This year, for the first time that I can remember, our net patient revenue is under guidance because we're going to try hard to keep people at their local institutions when it's safe for them, when it's good care, when it makes sense. I do think it's a shift, and we are working as quickly as possible to understand and to be compliant with what you're asking.
Thank you. Also, in the information that came on Friday, there were data with projections through 2029. And I made a bar chart of that. Matt, could you pull up that bar chart, please?
Pulling it up right now.
Thank you. From the information that we received on Friday, operating expenses are projected to grow nearly 40% from 2023 to 2029. Does that amount assume ongoing efficiency gains that you'd be working on during that time?
Yeah, so those assumptions in the financial framework, Member Walsh, those are really more geared towards the margin that that revenue and those expenses generate. In terms of the thought put into the expense projections going out that far, that we have to refine. It doesn't have as much detail and as much thought into it as our annual budgets. This is to generate where does the margin need to be to generate the resources that we need in the years ahead. Looking at the combination of days cash on hand, margin, debt service coverage ratio, and our average age of plant. So that's how we use the data internally. Each year, we're then taking this framework focused more on the margin and those other metrics to then say internally, what do we have to do if the revenue number isn't going to hit what we projected? What do we need to do in terms of expenses to get that number down to hit that margin that we've got in the framework?
I see. So there aren't any built-in efficiency assumptions with this. It's efficiency is not the point here. It's to be able to project the revenue and then looking at, well, what do we have to spend internally in order to be able to generate that revenue? So there aren't assumptions about decreasing operating expenses. So the net patient revenue is projected to increase about 38% over this same period. Given past under projections. Is the 3.4 billion in net patient revenue perhaps a low estimate out to 2029?
Yeah, again, our focus going out that far in this model, Member Walsh, is really about the margin. So every year we refine this to what we believe is going to be a closer approximation of both the revenue and the expenses. So the way that we use this internally, I wouldn't view this as the roadmap for where our expenses and our revenues need to be over the next 5 years. It's really a roadmap on where our margin needs to be over the next 5 years to generate an appropriate level of days cash on hand. It tells us in what year do we believe that we might be able to use some of our debt capacity to help fund our capital needs. But the precision in terms of the revenue and the expenses in this that you see here, that's done essentially every year, except for this year, given the changes in both. One of the things that we're modeling that in next year's framework, you'll probably see a little bit more refinement is one, looking over the next several years on getting the commercial percentage of Medicare down to a certain level, back to the affordability issue that we're trying to solve. And also projecting out what we think is going to be happening with Medicare, with Medicaid over the next several years.
Yeah, that's helpful. I think margin's a relative number, right? So you could have very high revenue and very high expenses and a small margin. You could have less revenue and much lower operating expenses and have a larger margin. So just so I make sure that I understand that. That's all. I know we're short on time. Thanks for being here and answering the questions. Back to you, Chair Foster.
Thank you. Member Teachout.
Great, thank you. I'll keep my questions focused. In the documents about the shared services across the network, you also had I'm just going to look at it here. You also had revenue attributed to the different shared services lines. And so I'll just focus on the 3 largest, and certainly it wasn't as big. But you had 15.5 million of revenue for the PHSO. You had 5.4 million in revenue for UVM-HN administration. And then you had just under $1 million for HN development. Can you tell me the sources of those revenues? Starting with the PHSO.
Before I get to that question, just to make sure the board realizes those revenues, when we're talking about allocating shared services, that allocation includes that revenue. So essentially, it decreases the overall expenses that we're allocating to all of our network partners. For the PHSO, that is primarily population health management payments, quality incentives, those types of things. So there's still 3 months left so pretty much all of the OneCare revenues, non-patient related revenues are in the PHSO. There's been some assumptions made for our Pearl ACO that will start in January. That is another component of the revenue stream there. As I mentioned earlier, the PHSO is starting to offer its services outside of the network. So it's actually providing services to the University of Vermont, which has created a new revenue stream. So that's the bulk of the PHSO. Development, I think that small amount there is related to, I think just some merchandise, if you will, that we're planning to sell. So UVM Health Network related merchandise, and then the 5 million in the UVM Health Network administration costs. And I'll have to get back to you on that one. That's not unless somebody else on the call is aware of that. I'm not remembering exactly what that revenue is there.
Thank you. So the PHSO one is actually increasing from FY 25 to 26 from, hold on, from 11.7 million to 15.4. So it doesn't seem to indicate like what's happening with One Care Vermont going away.
Yeah,
So
like I said, we've got a new contract with UVM. I don't know exactly what the amount is there, member teach out, but that may be offsetting the decreases that we're seeing from One Care.
Okay. And then when you allocate, you rightly guessed what I'm getting at. When you reallocate these back out to the hospitals, I thought you did it as a percent of their, I think their revenue. So is this getting allocated? The PHSO is helping also on the New York side and they're paying for their portion?
Correct.
Okay. Thank you. And then the other question I have is related to the liaison's recommendation of capping commercial prices at 500%. I think it's just for Blue Cross. Do you support the recommendation or are you supportive of it?
I think we haven't really spent the time really looking at what that would mean and the timeline to get there. And I think that's for the whole state as well. And so it'd be, I think obviously we would want to make sure that AHS and others have weighed into what that would look like and what that means. So I think it's really early for us, but our goal in general is if that's going to be what we need to do to make affordability more likely to happen here, that's what we want to support. So I think you can be confident that we want to do that and be sustainable, of course, to serve our patients. But I think it's too early for us to tell if that's the right number and also what the timeline is. And I don't know. That recommendation went to did it go to DFR? I don't know where it went, or AHS, but they'd have to look at that, I suppose, actuarially to see if that makes sense for the state.
Thank you. I noticed that you said that you're trying to get your commercial percent of Medicare down. That's a longer term goal. And those two kind of goals coincide. My other question is why, and I know a little bit that this is mixing apples and oranges, but why are you increasing your commercial charge masters when you're trying to get your prices down?
I'm gonna just keep pushing that back to Kelly.
Can you hear me? I seem to have some Teams problems, but can you hear me?
Yes.
Member Teachout, can you hear me?
Yep, we can hear you, Kelly.
Oh,
Go ahead.
Sorry, I'm having some Teams feedback. First thing, I want to just go back to your question and a little clarification. As I read the letter from the liaison team, it would apply to any plan offered on the exchange. So the impact does need to be analyzed on MVP and then obviously in the future. But right now we have our two plans. So just wanted to clarify that and have to do that analysis. And going back to the charge master conversation, and again, happy if there's follow-up questions, we can certainly discuss either in questions or with you and staff. So affordability and pricing, the charge masters, as you know, is not necessarily what our payers pay. It does relate to our financial assistance policy, which I know we have provided, and I would defer to my CFO colleagues to go there. As I described before, we are increasing our charge masters to, again, make sure we're not hitting any limits with lesser of, with any other components of the contract terms. We're working in detail with our payers to analyze this. So it's one of those, if you don't do pricing and revenue in conjunction, you get unintended consequences. So you could actually be getting reimbursement higher than what is charged, which is appropriate at times if there's outliers, and again, details in the contracts. But we're doing this as a matter to manage what we charge and the reimbursement terms with payers, which vary, and our charge master is the same across our entire payer. So it's not a different charge master per payer. So it's got to take in a couple of iterations of analysis there, and that's why we have that.
Thank you. Those were all my questions.
Dr. Merman.
I think I get to close out the questions today. So thanks for enduring. I feel like 2 years ago we had this mega hearing, and I think I said at the end it felt like a 12-hour ER shift. This was not quite so bad. I think this was more like an 8-hour shift. So this was much appreciated by everybody. I just have a few questions. This actually came up, Rick, you mentioned the New York funds flow documents. I just pulled it up real quick. And I have one question. I don't know if you can give it to me quickly, but it says percent of UVMMC patient revenue flow from New York residents as a line. And I was curious if you know if that's gross revenue or net revenue.
Pretty sure that's net, but we'll get back to you. We'll validate that for sure, Member Merman, Dr. Merman.
It's either's fine. So Dave works too. So I was looking at a updated Fitch audited financial from a year end, and it said that UVM HN had 150 days cash on hand at approximately $1.3 billion. And I did the quick math earlier. You said 131 days cash on hand at 9.4 million per day. So it's 1.23 billion. So I have a few questions for you on this. Do you use the same methodology to calculate days cash on hand as Fitch does?
It should be the same, but we'll take a look and see. Perhaps their average daily expense is a little bit off. Which time period were you looking at that Fitch report?
There was an updated year end. So it came out in May, but it was from the year end FY24. It's on the Fitch website.
Yeah, and just to be clear, the 131 that I was referencing is at the end of June of this year.
So in that 6 months, days cash on hand went down by 29 days. Can you explain why that's the case?
Yeah, so we're behind our margin targets, and we are waiting for some cash related to our employee retention credits. So we recognize that revenue when we submitted those, but we actually haven't gotten the cash for it yet. So that'll help to close some of that drop that you're seeing there. The other thing is UVM Medical Center's margin and the cash is very much back loaded. So the vast majority of the margin for the UVM Medical Center occurs in July, August, and September. Actually, this year, I think it's going to be just August and September related to the enhanced Medicaid revenues. So I think it was at 65 million that I think there was a question from one of the members that actually comes in just the last 2 months of the fiscal year. So that adds a significant amount of cash as well. We do expect that the cash will be lower this year than it was at the end of this year, but not. We do expect it to pick up a little bit from this 131 days cash on hand that we have currently.
Okay, so typically you would expect your cash to be higher after that Medicaid adjustment, and basically at the beginning of the first quarter of 26.
Correct.
Could you provide a projection of where you think your cash would end up at the October 1st, the beginning of 26? All right.
Yep, we can do that.
Thanks. And then I assume the denominator, like you were talking about, the denominator daily expenses has gone up between now and whenever this was last calculated. Do you re-update that throughout the year, or do you update the denominator at budgetary increments?
No, we update that. I think it's actually, I'll have to, I don't know if anybody in the team is on, but I think it's monthly that we're updating that average daily expense number.
Yes.
Did I say monthly? Hopefully I didn't say daily, monthly.
Monthly, yes.
Okay. All right, thanks. There was an editorial in the media last fall or winter around the challenging situation with the budget and enforcement that you had, that discussed that the revenue to UVM Medical Center is made up by 66, 2/3 comes from public payers. Do you know if that figure is accurate?
So Judy, I think that's about right. But
It is approximately, but I have not run the calculation, so wouldn't want to be quoted that that is still the current
So
makeup.
into the submissions to the board, it's quite different than that. Last year, this year, looking for the 25 actuals, looks like it's about 40% from public payers, and the rest is made up of commercial insurance, self-pay, UVM's self-insured group. I think you're looking at gross revenue, but that's not revenue. Revenue is dollars, not pseudo dollars. So I do wonder if there's an opportunity for a correction. I think that would help sort of lay the record a little bit more straight.
Have to compare what was stated and clarify if something was gross versus net. Because you are correct, what comes in doesn't necessarily end up as the proportion of our net patient service revenue, but it certainly comes in with the originating payer. But you're right, in terms of what drops down to cash, can certainly be different about what's actually making up margin.
Thank you. I don't know if you were available the other day when Matt Sutter gave his intro presentation on the hospital budgets. And if anyone was there, I was just curious if you were aware that 95% of the budgeted margin for Vermont hospitals this year is at UVM Medical Center, which provides about 50% of the revenue generation, 52, I think, in the state. Were you aware that 95% of the margin is currently budgeted at UVM Medical Center?
I was not aware of that percentage. I will say that it is important to recall that UVM Medical Center's margin isn't made up only of direct patient care. It is also made up of the extended care provided throughout the state through our retail and 340B programs, which does make up a significant amount of the margin as well. So
this was this was operating margin, so the retail programs didn't apply to that. But yes, appreciate that. The other striking fact from that was if you remove the UVM Health Network hospitals from the overall margin budgeted for all hospitals in the state, it's actually a negative margin. I don't think any other hospital is budgeting more than maybe just barely over a 1% margin. So it's a very tough time in Vermont. So I have the last thing I was going to say, I wrote up a little thing because I felt like I should make a comment and not a question. So I'm going to offer it here. But so UVM has a very big role in Vermont. Many people rely on UVM Health Network for their care, for their livelihood, and as we explored in the risk of closing dialysis, for their lives on a daily basis. All of this, while a substantial portion of Vermonters, people who live in Vermont, but hours from UVMC, who get care elsewhere, will never receive care at UVM Health Network, but they are impacted by the UVM Health Network. That impact could be having the option to go to UVM Health Network at a time of need, like the trauma that Dr. Harrington, Ramsey mentioned, but it all can also be impacted by the high cost of just having it there. Vermonters live far away in Bennington and Brattleboro, never get to UVM Medical Center or UVM Hospital. So many of the Vermonters who do not live in your service area, but they pay for some of the highest health insurance prices in the country because of the high cost of care at UVM Health Network. I know that it's clear, actually very clear today, that you guys, all of you people feel very committed to your hospitals in New York and to delivering care in New York. And I strongly support excellent care in those communities and wouldn't want that care to be eroded. But it's very hard for Vermonters who have some of the lowest median incomes in the United States to subsidize that care. This submission states that if there are events that impact your budget, this was in the risks section, that you would protect your margin so that you can be sustainable for the future. I would ask you to reconsider this. I would ask you to consider the non-UVM Health Network medical infrastructure, which is in far less stable footing. Our community health centers, our insurers, our independent practices. I would ask you to consider Vermont ratepayers and taxpayers, many of them who just never make ends meet. and definitely not with a 3 to 6% margin. A very small proportion of Vermont hospitals, clinics, small businesses, or individuals even come close to the equivalent of having an A bond rating. So please, while you enjoy massive market power, very high commercial prices, and a remarkably strong payer mix compared to the region that we live in, you also hold the responsibility to not take too much advantage of that position, and to not squeeze the others who maybe just inadvertently, but not blindly, get brought out of existence. So thank you for that, listening to that. Thank you for being here today, and that's all the questions I have.
Thank you, Dr. Merman. I'll turn to the healthcare advocate.
Mr. Chair, I don't have any questions or comments for the UVM Health Network, though I do have one for the board. Would you like me to make that now, or do you want to wait till public comment?
You can make it now.
Okay. I very much appreciated the concept about the liaison letter. I very much appreciated the concept that the liaison brought to the table of a cap on individual charges, a cap of percentage of Medicare. And I think I see it as a possible way for there to be an incremental step in the direction. It's going to take us a while to get fully to a reference-based price. And we don't want to shock the system too much in any individual step, and that maybe this could be a first step in that direction. I'll be honest with you, the 500% of Medicare just did not match my sense of urgency and concern for our system and our Vermonters. And so I ask the board if you are considering evaluating whether this is something that should be possibly put in play or possibly supported, that you give yourself some room and ask UVM in its modeling of this to model increments maybe between 4 and 500% of poverty, of Medicare, in order to be able to understand the dynamics and give yourself some room so that when you're making your decision, you have the numbers that you need. Thank you, Mr. Chair. And also, hey, thank you, UVM Health Network. Things I said at the very beginning of the hearing, or my questions earlier, I really mean it. We can both be critical and feel like we need to do more, and also feel appreciative for hard work that's been done.
Thank you.
Thank you, Mr. Fisher. I'll turn to Mr. Sutter and then public comment after that. But Mr. Sutter, does the staff have any follow-up questions?
Yes, I had a question about transfers into shared services, more specifically about how it interacts with the potential operating expense benchmark. If I could share my screen real quick, I think maybe it's easier to walk it through with a basic PowerPoint. So just using an example, let's say you have a hypothetical department with $100 in expenses and $10 in other revenue that lives entirely at a hospital. If that becomes a shared service, and let's say for this, we're assuming the hospital has 50% of the network revenue. If that becomes a shared service, they still have the revenue live on their P&L, but then there's an adjustment for the net expenses, so we don't double count. And then the allocation, their share of the allocated net expenses is then added back into their operating expenses. In this situation, the total network-wide consolidated operating expenses would be the same. But at this one hospital, it would have the apparent decrease of 45, just using the example numbers here. Do I have that correct? Is that kind of how this would interact or could interact?
That's correct. When that does move from just picking your $90 million figure, Matt, it means that hospital, when that allocation's made, they're going to get less expense back than when they were holding the expense in totality.
Great, thank you. That's my question.
Okay, thank you. And I'll turn to public comment. I'm going to The hand isn't raised, but I see Mr. Pratt has been here all day, and I really greatly appreciate that.
Yes, I have.
So, Mr. Pratt, if you want,
thank you for this. This has been very interesting and educational. So UVM, I'm in Rutland, Vermont, and I've had Federal Blue Cross Blue Shield since 2008. And with all the price increases, I still have it. I found out in January that the price of my Wegovy went from a $50 copay to a $616 a month copay. Now, I've been in the Vermont Health Assistance Program. Hope I got this. I hope all of you realize this letter that you sent out, that it's not going to allow me to get care in a local community because there's 3 qualifications. The first 2 I meet, the third I don't. I don't have an active care relationship within the University of Vermont Healthcare. So when you were asked about if there's going to be any reduction in services and you said no, what if I don't find a UVM healthcare provider? And let's say, how many UVM healthcare providers do I have to have? Do I have to have all of them that I now have here in Rutland? Or could I just find maybe a dermatologist, which it sounds like is up in Burlington? It's about the only place you can find one in Vermont. So what's that going to cost me to go up there? Currently, co-payments for me would be $10,200 a year because the Wegovy itself is $7,364 a year. That doesn't count any of the other medications. That is something I just can't handle. So when you have on your slides, I think there are 7, 12, 25, 52, 23, 27, talking about the pharmacy and the retail business, and you don't seem to think that that has any impact. Well, I've been trying since March to find out from UVM, talking to Matt Flint and other people, to find out exactly how many people got this boilerplate letter, because it doesn't have my name on it, doesn't have a signature at the bottom. But when I called the number at the bottom, they said that this is true. This is going to happen. So my runway ends in October. So October 1st, I've either got to come up with the extra 600 and, well, my whole thing. So it's going to be more than that. Or what? Or I don't get the prescriptions. How long would it take me to get in to see a provider? My wife just happens to have a provider, but she got a letter, but the way you had it in your system, it was Terry Loveco in Brandon, but they had her listed as T. Ray Loveco. So you guys didn't recognize her as being a provider. So unless we called up, which we did, and talked to a woman by the name of Kathy, and I don't know how many people you have answering the phones, but she said, well, okay, then I'll straighten that out and your wife's good till May of 2026. The only thing is we never got a follow-up letter, anything in response to let us know that she won't be kicked off on October 1st. So of that $70 million you're talking about, Chair Foster, I could recommend that some goes to Rutland, because Rutland's 340B program does not provide any prescription help for individuals. It all goes to their different medical centers or the ambulance services. So UVM's program, which has been a huge help to me and my wife, and I would just like to know how many other people or else got this letter, how it's going to impact them, what the cost is going to be. I don't need to know individuals. I just want sort of the aggregate. What is the big number? How much are you going to be saving by doing that? And how much are you going to be making? Let's say all of us that you thought you're going to have savings joined UVM system. You're not going to save any money or do anything that way, from my opinion. So those are just things I'd like answers to. And I have no idea how many people outside of UVM system is going to be hurt by that. But I know my primary care professional told me that there are quite a few of her people that are also in that program. So that's my statement, comment, questions, and I was hoping somebody could eventually tell me how many people are going to be impacted by that.
Thank you, Mr. Pratt. I think it's a fair question. This relates to something I think Member Teachout had asked. So EVM, I'm going to presume you don't have this information off the top of your head, but if you could send into the board how many people will be impacted by this change, and if there is a financial savings component to this change, to provide that as well.
Just Chair Foster, if I could just maybe I'll direct my comment to you, and then if we can get Mr. Pratt's information from you, contact information, maybe we can reach out. I'm assuming he's talking about the health assistance program. Yeah, that's right. So because your provider doesn't provide, your insurance doesn't provide the coverage, I think up until this year in that notification, we had expanded the health assistance program after COVID to go well beyond our service area. And I think this year we're pulling it back, and so that you have to be part of our provider service area. But let's get, if we can get your information, we'll follow up on that. Right now, Chair Foster, I think I have some numbers and I'm happy to get these to you, but we cover around 5,000 patients in that health assistance program. And I think the goal was to keep it at that around 5,000 patients. And so as a result of that and the continuing cutting in cost benefits there, that we've pulled that back. But we'll take that on, and if we can just get that contact information, we'll see if there's anything else it qualifies for.
Well, I appreciate that answer. But I was told there's about 6,000. And when you multiply that by 10,200, which is just mine, that's 61.4 or $61.2 million right there. That's a lot of money. That's a lot of money. So, and Matthew Flint at the pharmacy, who runs your pharmacy program, it's my understanding, has that information. So does your government liaison, because I've talked to Becca Balint and her people. So, but I give you or authorize, and I've authorized them to pass my information on. So if you want that, I'll be glad to get it to you.
Thank you.
Thanks. Mr. Pratt, if you, I think my email contact is available on the website. If you just send in your information, I'll send out Dr. Eben's info. I'll pass it along. And thank you. And thank you, Dr.
Thank you very much. I appreciate that.
No, good to see you. And thanks for being here today. Mr. Leclerc. Oh, sorry, actually, I'm out of order. Martha Lang.
Hello, I'm Martha Lang, and I'm here to talk about the University of Vermont's McClure Garage. I own a substantial amount of real estate directly across the street from the McClure Garage. That's my interest in it. My family was involved in the original Act 250 permit for the garage, 1982. I have monitored the behavior of the groundskeepers around the garage constantly. I live across the street from the garage. I'm very concerned that they want to try to tear it down. I asked to do a study, an engineering study. I'd pay for it myself. And UVM denied me that right. And no engineer is going to work for me if I don't have the permission of UVM. And so UVM Medical withdrew their certificate of need, saying that after 2 months they would have an engineering study and it would cost them $28,000. I'm asking you people to ask them if they ever did the study, and if they did, what the results were. I'm of the mind that the McClure Garage is not in the condition that UVM Medical Center says it is, and I'd like to prove it, okay? I'm a very good neighbor, by the way. I don't cause any trouble except this. Now, the next thing is I went through as best I could that budget and all the information. And interestingly enough, one of the categories under other revenue was there's $7.7 million revenue from the garage and the cafeteria. Just as I would suspect that most of that revenue is from the garage. That's a very small cafeteria up there. They're probably lucky if they break a million. Why can't the money that's being generated from the parking garage go to rehabilitating the McClure garage? And it's a terrible idea if they're cost cutting, which they want to do, means that they're going to delay necessary maintenance. I own real estate. The last thing you want to do is delay maintenance because it only gets worse. You want to try to contain the issue and work from there. It's been a long day. I appreciate all your hard work, and I am very grateful that I can post my thoughts and comments to the Green Mountain Care Board. Thank you very much. Thank you.
Thank you very much, Ms. Lang. I have to admit, I haven't re-reviewed the CON application recently, but I think it's a fair question about the study. So I guess if UVM, if you have the information available as to whether or not the study Ms. Lang referenced has been done, that might be helpful.
We can get you that information.
Ms. Lang, when we get the information, we'll post it publicly. But thank you for, yeah, of course. Thank you for being here and for your comment. Mr. Leclerc.
Alrighty. I got a birthday to go to, so I'll make it brief. The self-pay percentage in the budget that was submitted is the same as 25. That is not going to happen if people can't afford health insurance. I'm one of those people who's considering it and dropping it. I don't have the extra 15 grand to pay in a premium, and I'm not going to use it. Sorry, I'm just going from my notes here. The leadership is getting a 4% raise based on my math, and their Medicare star rating is going down. That's unacceptable to me. I'm sure they deserve it. The last thing too, the 500% of Medicare pricing is outrageous. I didn't even know that we had CPT codes that were 500% or more. I run a PT clinic. My contracts are between 130% and 150%. And at 150%, it's a lot of money for a lot of people. And I cannot stand that their pricing is 500% of Medicare. That's ridiculous. And I would just say a couple other things because I'm the claims person too. Why are my claims processing 4 weeks after UVM's claims are supposedly going through, and the patient is telling me, why am I paying my deductible to you guys? UVM should have already submitted it. I don't know the answer. I want to know the answer. And it's good to know that there's public board meetings for the UVM Medical Center here. I will be attending those now. And then just one other thing. That was my landlord from my junior year, so I'm very familiar with what she's talking about. I can't stop laughing. Lastly, if there is any power that you have, Chair Foster, to lower the pricing for Blue Cross and MVP, I don't care about Cigna personally, please do so. We really need to get a business plan, and I do not want to give Cigna my money next year. I will do that though, if it is the cheapest option. Please. It's absurd that they have a $72 million margin. My margin is 1%, and I can give every single one of my employees a 4% raise. That's ridiculous. I'm sorry. And I'll write some public comment too as well. But I gotta go celebrate my mom's 56th birthday, so I gotta go.
Great. Thank you, Alex, for your comments. I believe the board's decision on the QHP rates is currently scheduled to be published on August 22nd, so 11 days. And happy birthday to your mother. Any other public comment at this time?
Thank you very much for taking mine.
Yeah, thank you for being here, Mr. Pratt. Okay, UVM, thank you very much for all your hard work and your thorough and candid answers today. It really is an important part of the process, and I appreciate it very, very much. And I respect the work that you all put in the budget and in the follow-up. We appreciate the partnership on that. Is there any new or old business for the board? Okay, then I will move we adjourn.
Second.
All in favor, say aye.
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 Aye. We're adjourned.